I think we'll start. It's 5. So we welcome you all. Good evening. On behalf of Dr. Shroff Charity Education Academy, I welcome you all to this webinar. The thought behind the webinar was to give you a virtual learning platform for this advanced form of surgery called DMEK, which is an upcoming surgery for all these cornea surgeons. We have a panel, a very expert panelist with us and a lot of good speakers on board. The webinar will be held in 2 episodes. Today in the first episode, we will be discussing the fundamentals of DMEK. And in the second session, which will commence on 14th of June, we will learn the tips and tricks to manage the difficult scenarios. Before I introduce you to our faculty, I would request all the participants to keep their videos off, and we would welcome your questions on the chat books, which will be answered simultaneously, and some of them we will see the time and take them in the discussion also. So we have on board with us our expert panelists, Dr. Umang Mathur, who is the Executive Director of Dr. Shroff Charity Eye Hospital. And we have Dr. J.S. Satyal, who is the head and the professor and head of ophthalmology of Cornea and Cataract Refractive Surgery Center at RP Center, All India Institute of Medical Sciences. So I would begin with Dr. Rajesh Fogla. Handing over to him, he will be speaking on why DMEK. Dr. Rajesh Fogla is the Director, Cornea Clinics, Apollo Hospital, Hyderabad. Over to you, Dr. Rajesh.
Thank you, Nidhi. Good evening, everybody. The topic I'll be talking on is why DMEK. In the evolution of endothelial keratoplasty, we have come a long way, starting from posterior lamellar keratoplasty or deep lamellar endothelial keratoplasty, moving on to decimal stripping endothelial keratoplasty, and then decimal stripping automated endothelial keratoplasty when it really became popular worldwide. And in the current scenario, decimal membrane endothelial keratoplasty or ultra-thin DSEK are the most frequently performed techniques. The advantages of endothelial keratoplasty compared to penetrating keratoplasty is that it results in faster visual outcome because the surface topography is maintained. It's done through a smaller wound, greater tectonic stability, and because you transplant a lesser amount of donor tissue, you have reduced rejection rates. This paper published by Mellis back in 2009 highlighted some of the advantages of DMEK being minimally invasive. You don't require any expensive instrumentation. You have a faster visual recovery with minimal refractive shift and reduced risk of rejection and better utilization of donor tissue. And if we look at it a decade later, most of these points still hold good. If you look at the data from the Eye Bank Association of America for the 2019, you will find that there is a rising trend of DMEK surgeries being performed. And in the last year alone, there has been almost like a 41% increase in the DMEK procedures. The donor preparation, in some of the countries, especially in the United States and Europe, you have eye banks preparing the donor tissue for you. So you get them as pre-stripped tissue. But in our part of the world, we still have to prepare our donor tissue. And this is fairly reproducible, as we will hear in the later presentations. And the tissue loss rate is less than 2%. The donor age, however, compared to DSEK, where you can use donor for any age group, even including pediatric donor tissues. In DMEK, however, you need tissues which are within the age group of 55 to 75 years, ideally. And the younger age group, the tissue tends to curl more. And as you go towards older tissue, you find that this tendency reduces. There are some instruments that can help you prepare that. This is the pre-stripped tissue that I was referring to. And you get the patient-ready DMEK tissue where the donor is already stripped, stamped, and loaded into an injector. One of the advantages of DMEK compared to the other forms of endothelial keratoplasty is the speed of recovery. If you look at this clinical case, you look at the pre-op anterior segment OCT, you can see that the cornea is significantly swollen. And if you look at day 3 for post-operative photographs, you can see that the corneal edema is almost resolved, and this patient could see 20/40 even by day 3, day 4. Looking at eyes, fellow eyes, where one eye has undergone DSEK and the other eye has gone DMEK, you see that the endothelial cell loss is comparable. But when you look at the visual outcome, you find that there's a greater percentage of patients that achieve 20/20 or better. And in their series, you can see almost 80% were 20/25 or better. This is one of my cases where I did one eye, a triple procedure of phaco, IOL, and DMEK. And within 1 week, the patient was seeing almost 20/20, and the patient wanted to have the surgery for the fellow eye, which we did. And 2 weeks later, the patient had a good recovery in both the eyes. So this is a procedure which you can do even sequentially in both eyes. The other advantage is that the corneal anatomy is better maintained in DMEK. So if you compare the anterior segment OCT of DSEK and DMEK, you can see that in DMEK, you can hardly figure out any change in the corneal anatomy. This paper published in 2014 looking at fellow eyes, they showed that the posterior curvature in DMEK remains normal, whereas in DSEK, the posterior curvature becomes much more steeper, which can account for the hyperopic shift that occurs after DSEK, and you have to make modifications when you choose your IOL power accordingly. There's another paper looking at the triple procedure using DMEK, and they found that the addition of cataract surgery to DMEK had no adverse effect on the graft adhesion or outcome or postoperative complications. And this interesting paper from Gerrit Mellis published in 2011 tried to explain why you don't see a refractive shift after DMEK. Because of the induced edema, you have changes in the posterior curvature, which induce a little bit of a myopic shift. And the immediate postoperative period, because the central cornea edema clears faster, you get something like a hyperopic shift because the posterior curvature becomes a little bit more steeper as the peripheral edema is still present. But over a period of 2 to 3 months, as the edema settles down, this hyperopic shift also goes away. So you see a minimal hyperopic shift. And we all know that the rejection rates of DMEK are far lower than compared to DSEK or penetrating keratoplasty, usually in the range of about somewhere between 1% to going to about 4%. So this is one of my cases, the DMEK done somewhere in 2009, and he's still 11 years down the lane, still holding on 20/20 vision. He's off steroids now and still maintaining the left eye, which is a failed penetrating graft, 8 years follow-up. He still uses some soft steroids once a day. It's still working very well, no evidence of rejection. This paper published in 2018 by the American Academy looking at the DMEK outcomes, and compared to DSEK, they said that the visual recovery, visual outcome, rejection rate, DMEK is superior to DSEK and induces less refractive error. How about the learning curve? This paper comparing an experienced surgeon last 100 DSEK cases to the initial 100 DMEK cases, they found that the visual outcomes were better in the DMEK group. They did not have significant complications. The pupillary posterior synechiae were slightly more. A greater number of eyes required rebubbling, but more eyes reached 20/20, almost 55% compared to 13% in the DSEK group. How about comparing with Ultra-thin DSEK? So when Busin published this paper in 2013, he showed that the results of the ultra-thin DSEK were much better than the conventional DSEK procedure by transplanting donor grafts, which were less than 100 microns in thickness. And almost the results were almost comparable to DMEK. But if you look at the visual acuity recovery curve on the right, we can see that still DMEK kind of is the overall results are better. Last year, Chamberlain published this randomized trial comparing ultra-thin DSEK and DMEK. And they found that still, till the time period of 12 months, DMEK still outperformed DSEK almost by 1.4 to 1.8 microns. And also the induced high order aberration, they found that with ultra-thin DSEK, you had more posterior high order induced aberration. And that can also explain why the quality of vision was better with DMEK compared to DSEK. So if we look at all this data that we have, we find that if we go back to the initial paper and whatever advantages were alluded to by Gerrit Mellis, DMEK is still minimally invasive, takes shorter duration of time, no expensive instrumentation, recovery is faster, minimal refractive shift, somewhere in the range of about 0.5 diopter hyperopic shift, you can say, the reduced risk of rejection, and you can have better utilization of donor tissue because the anterior unused stroma can still be used for an anterior keratoplasty. So I think with this, I end my presentation, and these are the advantages of DMEK when you compare it with these.
Thank you, Dr. Rajesh, for that information, such an informative. Dr. Tatyal, do you think we are seeing the trend even in India from shifting from DSEC to DMEK like we shifted the time from PK to DSEC?
Yeah, that's true, Nidhi. And what Dr. Rajesh talked about in India also in last 3-4 years, there has been a significant shift towards endothelial keratoplasty. And from DSEC surgeons, they are now all, I think almost 90% of people have shifted to DMEK in a suitable cases. Though there is a definite learning curve in situation because we have to prepare our own donor tissue or a role, which Dr. Rajesh nicely showed. So there is some challenges there, but I understand the shift has been there. If I look into our own data from National Eye Bank, in the endothelial keratoplasty constitutes around 40% of keratoplasties. Of that, around 50% is now DMEK compared to DSEC, which was almost 100% 3 years back. So there is definite change, and that's for a good, I think, because this is more physiological surgery for patients.
Yeah, so seeing that encouraging change, we'll go on to our next speaker, Dr. Vikas. So from donor preparation of DMEK, we'll be going on to teaching the correct DMEK technique and going on to pearls. So handing over to Dr. Vikas Mittal, who is the director of LGI Institute, Ambala. Over to you, Dr. Vikas.
Thanks so much, Nidhi, and it's a wonderful platform. I think you have done a phenomenal job. So now Dr. Fogla has already told you about why DMEK is needed. I know I'm talking to you, all of you are cornea surgeons and few must be doing DMEK, but those of you who have not done DMEK or, still, just a minute. Is it coming? Okay, so what we are going to do is we'll just see how these, what is going on? There's some, I think it will come like this. Okay. So what we are going to do is we'll just go through, I'll take you through what are the steps of descemet membrane peeling or the donor graft preparation. So there are basically 4 steps that we are going to see, and I'll take you through one by one so that you can actually do it yourself. So in principle, what we are dealing with is a descemet membrane, and descemet membrane is 5 times almost, the epithelium is around 5 times thicker than the endothelium, descemet membrane. So we have a field of epithelium which is around 50 odd microns, and descemet membrane is only 8 to 10 microns thick. Basically, we are going to refine it twice and peel it twice. So first will be the initial trephination, the peripheral one. Then we'll peel it by 70%, and then we'll do another trephination and then the final peeling. So 2 trephinations and 2 peeling that will cover your whole DM donor preparation in DMEK. So once you are in OR, you'll have to make your trolley ready and ensure your rim is perfect. Select donor tissue. You have to select between 45 to 55 years. These are best, as Dr. Fogla also highlighted. Younger tissue are too elastic and elderly are too plastic. Initial cases, you should take good cell count tissues. That is always good. Most of the instruments that are needing are already there in your OR. The plain curved forceps you can use for peeling. Additional a P marker and 3 mm skin biopsy punches generally needed. So you take the tissue, ensure that you remove the fluid between the Teflon block and the tissue so that the tissue gets stable. Remove all the iris, because sometimes, this iris, it gets stuck and mingled with the iris and it becomes really messy. So once your rim, the CS rim or donor is ready, you do your first trepanation. The peripheral trepanation, you just measure it. Most of the time it is around 10 to 10.5 millimeters. So you do this trepanation. Important here, the pearl here is you don't go full thickness. You have to tap it. The basic idea is to go around 75 to 100 microns into the donor graft. If you don't cut, then if you don't get a cut, it is very difficult to peel and the chance of tear will be high. And if you go too deep, then it will be difficult to find the edge of that descent membrane. If you have incomplete cut, you can use MVR, make multiple stab incisions and ensure that you have cut 360 degree. So once you have made this, check whether you have got a good groove, 360 degree, and instill trypan blue in this groove that you have prepared. This will make your DM thick and you'll be able to recognize the edges of the DM easily. When you are removing the trypan blue, instill BSS from one side and keep Marisol sponge on the other side. Avoid instilling the BSS directly onto the endothelium. If after trypan blue you see your graft like this, where stress triad, lots of stress lines, these are not good tissues, better to reject it because you can get tears in that areas. Instead, in case you feel there is a suspicious tissue, you can instill the trypan blue as a first step and decide whether you really want to take the tissue or not. Going forward, you have done your first partial trepanation. Next is you have to lift this DM in 360 degree. All you will have to do is take this Sinskey hook and just very gently nudge this descent membrane all over. You have to create 2 millimeter of ledge, 360 degree of descent membrane. If you have done this step nicely, there'll be very less likelihood that you'll get a tear. And then once you have lifted the ledge, then now you have some place to hold. You can use your simple curved suture tying forceps and start peeling. You have to keep an eye on the edges, because the edges from where it is getting peeled, that is an area where you are likely to get the first tear. The force of the vector will be towards the opposite limbus. You have to be horizontal, parallel to the surface, cross the midline, and then you ensure that you have peeled around 70%. Don't peel completely. After 70% peeling is attained, you let the DM lie flat. Going forward, you'll have to create a stamping well, or you'll have to punch the stroma from where you'll do your DM stamping so that you can identify the orientation well. So this is the DM where 70% peeling is already done. This fluid is absorbed by using Marisol sponge. Take 3 millimeter skin biopsy punch and punch this stroma, make a hole in this stroma. Ensure that stromal button is not lost. It is very important. You have to find it and keep it where it was there. Going forward, this descent membrane, now it has already been peeled, a hole has been created. Use a fluid wave to place the descent membrane back in place, and then use a sponge all over so that the DM lies flat, and then you can store it on the trolley. So what I generally do is I do this step and then take the recipient cornea and do our desmotorexis and then do stamping. You can do a straightaway stamping as well. So first peeling, first trepanation is done. Now you'll do stamping and rest of the trepanation and peeling. So this is already peeled and there is a button, hole is already there. Now you flip the Teflon block and you flip the graft. Now the endothelium is facing down. Use a Sinskey hook and just remove this stromal button which you have already created. So now what you are seeing over there is a stamping well. This is the descent membrane is already there in this well, and you will be stamping on the stromal side. Very important is drying it. You need to ensure that the whole stamping well gets dried up, and then you smear the P marker with gentian violet and gently touch it. Don't force it, gently touch it, and you'll get a very good stamp over there. You have to ensure that it is nicely dried up. So wait for 30 seconds, then put this stromal button back. And it is not a good idea to smudge. So smudging we must avoid, and this mainly because when it is not dry, then only it gets smudged. If you have inadequate P mark, you can again use a Sinskey and ensure that this mark should be very good, nice and bright. You should be able to see it because this will help you later on. So next will be the trepanation number 2. So the trepanation number 2 will be within the first trepanation, and it should ensure it encompasses the stamping area. Most of the time it is 8 or 8.25 millimeters. Again, only taps, not forceful punch. And once you have made your second trepanation, instill trypan blue and ensure that you can see that area well. Once this trypan blue is washed off, the peripheral rim of the descending membrane, that is between first definition and the second definition, is cut and removed. It's peeled off. Ensure if you have an attachment, never cut with vanas, rather use MVR and make multiple stab incisions. So once this second definition is done, this is only 70% has been peeled, 30% is still remaining. You'll peel off rest of the DM and the whole descending membrane is peeled off. Now here 2 minutes trypan blue installation is very important, because you have to ensure that your DM roll is nicely stained so that you can see it when inside the AC. So next will be the aspiration. Wait for some time, let it get rolled, and then aspirate it with your customized injector, whatever injector you want to use. You should not touch the DM straight away. You go in the fluid and your tip should first touch the fluid, and it should not touch the DM straight away. The correct orientation will be bevel of the injector up, and the empty side of the triangle that we see in the DM roll, that should face down. So that means once you have injected, and it should not be a sudden push, it should be gentle, very slow, step by step. And this will be the correct orientation once it is in the injector. Bevel is down, empty side of triangle of this roll is up, because it curls towards the stroma, so that once it goes inside, it will open in the correct orientation. And then you can straight away use it, or you can wait, and if you have any other step that is remaining, that is done. So these are the 4 steps. Once it is done, you'll have to practice it. I know that these days it is difficult to get the rejected tissues, but I'm not sure. Yes. Oh, I don't know if it will play. Oh, I don't think so. What I wanted to say is that you can use onion peels. The inside of the membrane of the onion, this resembles exactly like desmoid membrane. So those of you who have never had a feel of desmoid membrane, this behaves exactly like a DM roll. You can practice all your first definition, initial peel, stamping, then final peel, DM roll, have a feel of it, all those things. But it is important to spend your time in wet lab before you take up your first case of DMEK. Thank you so much. I thank team of LJ and all the trainees who come. We learn a lot from all of them. Thank you so much.
Dr. Vikas, thanks for that extensive explanation. And there is a question for you. It goes like, if you have marked in your video, the marking of the DM has been done quite in the center. So they want to know whether it should be marked in the periphery, or is it okay to mark towards the center?
So you can mark wherever. The best part is that if you can make it slightly eccentric, it is good. But we know that there are good cells, good endothelial cells in the periphery. So you want to spare that. This junction violet dye per se is endothelial toxic, and you'll have to just take care of that part. So that's why it hardly matters. So I don't think that we give very much importance to that. But yes, the area where you have a stamp, that area sometimes stays edematous for some time, but later on it resolves well.
Also, because would the visualization of it after once you're unfolding would be better if it would be in the center or in the periphery? Would
Yeah,
that
that's
be effective?
that depends. That depends how bad is your cornea. But sometimes, suppose you have a failed PK graft, where in the periphery you have very dense opacity. Those kind of cases you can just look into it. But I think how good is a stamp, that is more important than the location. The very good stamp and very good use of trypan blue, that makes a huge difference once the graft is inside.
And I think Smita wants to know which refine did you use here?
So we use normal Madhutrifine that we use for normal penetrating keratoplasty. What I said is ensure that you just tap it. What I generally do is I just place it and tap with my index finger 5 times, and that generally does the job. So it's just that once you have done 2-3 times, you'll know that how deep it is. So to me, I don't think there is any need of taking a partial thickness Trifines, although these are available.
I think, Smita, you would be taking the skin punches for making the small trepanation, or you may take what you get with the Boston K-Pros, the 3 mm punch for making that window.
So
Right?
she's asking for stamping well, right?
Yes.
Yeah, you are right. For stamping well, yes, for that 3 mm skin biopsy punch, the same that we get with K-Pro.
Yes. So I think with that, we'll go on to Dr. Sunita. Thank you, Dr. Vikas. Dr. Sunita will be talking about the eye bank perspective in DMEK. Over to you, Dr. Sunita. She's the consultant cornea refractive surgery, LV Prasad Eye Institute. She's also heading the eye bank there. Over to you, Dr. Sunita.
Yeah,
I'm
thank
not
you,
able to
Nidhi.
stop the
Because
share.
can you stop share? Then
Yeah,
I
I'm
can.
just trying that, but
Yeah,
looks
yeah.
like that.
Maybe we'll take a question by the time Dr. Sunita is trying to set up her screen. I will ask Dr. Umang sir, do you think there is a changing trend towards DMEK now, and it's going to replace DSEC? However, we have PBK, although to be the major indication in India, unlike in Western world where Fuchs is the major indication.
Yeah, so there is a change in trend, no doubt. And even with the PBKs and or the Fuchs that we see, oftentimes there are clear cases which would do well with the DMEK. And so one does see a change in the trend towards DMEK. And also, I think the other advantage with DMEK in Indian perspective is that the surgeon has control of preparing the tissue, because oftentimes surgeons may not have an automated system to prepare the tissue for DSEC. And so they see it as an advantage that they can control, and also the cost comes down. But you're right in saying that a lot of our cases are untidy PBKs with which don't have a lens in the bag, and there's vitreous and iris is all over the place. So those are not the easiest cases, at least in the hands of novice surgeons. So it may never be as popular, I think, as it is in the West, because we see more PBKs than Fuchs, and the cases are often not that clean. But I think there's a trend and there is a place for DMEK, especially because the follow-ups become much easier and steroids use is less, and of course the visual acuity is better. So there is a trend towards DMEK.
Thank you, Dr. Umang. Yes, Dr. Sunita, I think you're good to go.
Yeah, thank you, Dr. Umang and Nidhi. So I'll be covering some aspects which are related to the tissue selection in DMEK surgery. Now, when we look at the DMEK role, the behavior of the graft is somewhat dependent upon the age of the donor, because we all know that the desmus membrane, the physiological properties change with the age. Now, the younger donors, if you look at the tissue characteristics, the younger donors are thin, and in these cases, hence the DM stripping can be somewhat difficult. The younger donors also are elastic, so there may be a surgical difficulty in unfurling a very tight scroll. When you look at the older donors tend to be somewhat brittle and they are less elastic. And in some cases, and some very older donors, you may not even see that it forms a scroll. So we don't know which side is which, because we know that the endothelium is on the outside. So if it doesn't form a scroll, we don't know which side is the correct side. So marking becomes important in little older donors to know the proper orientation. Now, what are the ideal donor age parameters? We can use tissue which are above 40. Upper age limit, there's no upper age limit as long as the tissue, the endothelial health is good in a tissue. Yeah, however, as Vikas pointed out, the ideal age for a DMEK graft would be somewhere between 50 to 70 years, because these balance between the endothelial cell counts and the tissue characteristics which are related to unfurling the desmus membrane rule. So 50 to 70 years is a comfortable to begin with, but yes, you can do with extremes in 40s as well as above 75, 80s also, if the endothelial health is good. Now, based upon the anterior chamber characteristics of a patient, like based upon the indication of the surgery, we need to plan a suitable donor. Like it's like if we have a donor who has a recipient, a patient who has a very deep AC, such as what we see in myopic eyes or post-vitrectomized eyes, here the chamber can be very deep. So in such cases, it is not good to select a tissue with a very young donor, because unwrapping the graft in these cases can be very challenging, especially in those cases post-vitrectomized, because as you see in the second cartoon, there's not much support from the iris tissue also and from the cornea. So the chamber becoming very deep, if we have a very tight scroll, the roll has a tendency to scroll back into its normal conformation. So it's a little difficult, and we'll end up having more loss in these cases. So here, tissue should be somewhat of little older age. What is the impact of age on donor graft survival? Now, this is one landmark study from the cornea donor study. We don't have our own data, but yes, from the cornea donor study, we can take several cues. There was no difference in graft failure apparent at 6 years. And if you look at one more publication, we see that at 10 years, the graft survival was somewhat better with the donors which were less than 70 to 71 years, and somewhat lesser with donors which were above the 72 years of age. There was a significant difference at 10 years, not so much apparent at 6 to 8 years. So obviously, you know, like if a graft is surviving up to 10 years, that is a pretty good longevity for a graft. So there's no need to reject a cornea because it comes from an older donor. Now, in the DMEK, we have more steps in graft preparations. Cleaning is needed. We all know that track blue is somewhat toxic to the endothelium and there's more manipulation may be needed. So IBank has set up a baseline endothelial cell density, which will be good for a PK, DSEK, and DMEK. So for PK, just as the limit is 2000 cells per millimeter square for a PK. For DSEK, we set it around 2200, and for DMEK, it should be anywhere about 2400 for DMEK surgery. And of course, like you can choose based upon your indication. So your exact tissue characteristics may be dependent upon the patient's age, as well as the indication for which we are performing the surgery. For a patient who is a little older age, obviously it is fine to use any age, and you may not ask for a very high endothelial cell density for those cases. That balance has to be maintained. Now, what about the paired cornea? Now, it is seen that if we have a cornea, if we have two corneas from the same donor, if one cornea is giving a trouble, it's not good to select the other cornea also for a DMEK surgery, because corneas where Descemet's membrane is difficult to peel usually come as mated pairs. So if the first cornea is given trouble, it is better to use the second as the same donor for another surgery, because this may not be very common to see, but some of the corneas have a difficulty in peeling of the Descemet's membrane. These are related to the inherent attachments of the endothelium Descemet's membrane to the posterior stroma. So there's a tendency to tear in some of the tissue. So this is a very important thing. If some tissue you have, and we have two corneas, if one cornea is not behaved well, it is better to disregard the other cornea for a DMEK surgery. What about the preservation media? Now, we have two popular preservation media in India, Cornisol and the MK. Now, we know that in Cornisol, the cornea is somewhat compactor compared to the MK. And Cornisol also makes the cornea somewhat sticky. So for the ease of preparation, it is important to rinse the tissue when it's stored in Cornisol. And this we have seen in quite a number of cases. Like it is much easier to prepare from an MK medium versus a preserved cornea versus a Cornisol, because cornea tends to be somewhat compactor. And one more important thing to remember is, like when we have the tissue, it is important to warm the tissue before donor preparation, because when the cornea is under very cold temperatures, there's more amount of cell loss during tissue preparation, which happens. Apart from the fact that Cornisol we need to rinse for the reasons that it is somewhat sticky, to ease in the DMEK roll preparation. What about cataracts and refractive surgery donors? Now, pseudophakic donors, the corneal incisions of cataract surgery may limit the graft size. So it is important in these cases to decenter the trephination and also avoid the areas of the scar. Now, this all depends upon how healthy the endothelium is in these cases. So if the endothelial count is good, we can use these donors. Obviously, with some bit of decentration may be required based upon the incision size. With LASIK and PRK, it is fine to use these corneas. With post-RK, again, we don't see too many cases which come with post-RK, but then again, if we have a cornea, it has to be dependent upon case-to-case basis. If the incisions are too deep, obviously it's not good to select these corneas for a Descemet's membrane DMEK roll preparation. What about systemic history of diabetes and chronic renal failure? Now, it has been very reported in various studies that diabetes interferes with the tissue preparation. Some say that the cornea becomes brittle and there's more risk of graft failure because of poor endothelial health. And now these are not very consistent findings, and we also don't see that much with donors who are from diabetes. It's not that we see them having a problem all the time. But yes, now when we get the donor history of diabetes, now it's a whole spectrum. Diabetes is a whole spectrum. You can have a diabetes without any complication, but there are cases of diabetes who have an associated systemic complication in the form of renal failure. Now, these corneas may not be ideally suited because they have a poor endothelial function, which we have seen in some of the donors. So I think it has to be based upon the individual tissue parameters. If counts are good, this is okay to use. And we don't see much of difference with regard to systemic history of the donor. Now, this is something which we had a discussion with Dr. Basak, and he remembers this paper. And decentering the cornea, and Vikas also mentioned this. So we know that the superior cornea is somewhat has a protection from the upper eyelid. So the cell density tends to vary from the central to the mid-peripheral cornea to the extreme periphery. So there's a 5% difference in the mid-periphery. The central part of the cornea is somewhat 5% lesser than the mid-periphery, and the peripheral part of the cornea has 10% more than what we see in the central cornea. So if you have some way of knowing which is the superior side, you may decenter your cornea superiorly to have the advantage of more healthy endothelial cells in these corneas. So these would be my take on eye bank related things on DMEK graft preparation. Thank you.
Thank you, Dr. Sunita. Dr. Tityal, such specific requirements for having DMEK tissue, does that limit us? And what's your take on it? Do you do a pre-op examination of the tissue in the ward? What is your methodology?
I think Sunita has explained everything so nicely. We also assess these tissues in the eye bank. And one important thing which she nicely highlighted, like donors which are like, we take 50 to 70 as a age group, which is better for a DMEK tissue peeling. But this is a group where most patients would have undergone cataract surgery also. So I would be a little more careful to examine these tissues if they have a large scar like SICL surgeries, which is so common in the country. So these scars can be a real trouble for a peeling. And especially those tissue can be isolated for other surgery rather than for DMEK. Otherwise, normally for RK patient, we'll avoid those cases. Mostly they'll have some endothelial problems as such. Otherwise, as far as we are concerned, we use cortisol as a preservative medium. So we don't have any idea about MK medium being a better medium for a peeling tissue. Maybe true in a sense. But yes, a pre-assessment for tissue has to be done carefully for these patients.
Thank you, Dr. Tityal. I think we'll go on to the next talk by Dr. Praveen. Dr. Praveen is a director, Cornea Institute, LV Prasad Eye Institute, Hyderabad, and he'll be talking to us about his pearls of on donor preparation in DMEK.
Thanks, Nidhi, and thanks everyone for joining in this webinar on a Sunday evening. So some fantastic points there made by Vikas and Sunita. So what I will do is actually share a video of a donor preparation that is almost in real time, but some steps have been cut out, and point out important steps in the donor prep, which I think I've learned over time. So what I usually do when I take a donor tissue is always mark the epithelial side of the donor tissue after wiping it dry, and then try and place it in the Teflon block, and then ensure the first important thing is to look at the distance between the Schlemm's canal or the trabecular meshwork and the center of your graft, because this is very important from the point of view of getting a central punch. If you're a little eccentric, then you will probably be including areas that are too peripheral, which will be difficult to peel. Once you do that and you activate suction, you'll see that there are some horizontal lines that come in. So I typically use a 9.5 millimeter trephine for my initial trephination. This is the outer trephination. This is a fresh, new, sharp trephine, so you don't need to punch down too much. So you can just tap on the surface. So as you tap on the surface, it usually dissects the Descemet's membrane and also some bit of the posterior stroma. Then a little bit of trypan blue to make sure that you mark out the edges of where your trephine has contacted the endothelial cells. And once you do that, you can make sure that you wash out all the extra trypan blue by putting in fluid from the outside. The next thing that is desirable but not essential to do in all cases is to remove the peripheral frill of the Descemet's membrane that you're not going to use anyway. This is useful because in some cases, especially if you're using an older trephine, there might be some additions between the peripheral frill and the central Descemet's membrane, and it'll reduce the chance of having tears. The next step is to use an instrument like a Sinskey or any other hook to ensure that you go and lift up a bit of the Descemet's membrane. And the tip here is the fact that if you look at increased areas of staining of the Descemet's membrane, try and elevate it from that area it seems as if those areas, the desmase is less adherent, and usually the desmase membrane can be lifted up more easily. Once that is done, I usually use a fine non-tooth forceps just to lift the desmase membrane and go all around like a frill, basically ensuring that the peripheral circumference of the donor desmase is lifted off the stroma all around. And then once that is done, I ensure that I stop where I had started. So it will be useful to use a landmark, like a little bit of residual iris tissue to know where you started, so you also know where you end. After that, it's very important to release the vacuum if you're using a vacuum punch, because you don't want these striae to form, which actually can lead to radial tears. Then hold the desmase and then again pull slowly towards the center, ensuring that you're following the leading edge where the desmase membrane is being lifted off, and make sure there are no areas of lag and it's getting lifted off in a straight line. This is usually done in several attempts. In the initial periods, you can do it in about 6 or 8 attempts. Eventually, you can move to about 3 attempts or maybe even 2. So I'm just doing it in 3 triangles. So whenever I finish lifting one area, I go right up to the center, which is where the mark is important. And then I let it be. And then I ensure that I wipe off or remove all the excess fluid from the periphery, and then again try to recenter the graft on the marking hole. What you'll see here is when you put the second refine on, sometimes the graft will get decentered. So you need to make sure that that mark that you've made right in the beginning is in the center. And if your refine holder has these legs, make sure that your sterile rim is not too large and keeps getting displaced to the periphery. You can use an 8 or an 8.25 punch for the second trepanation. This is the standard 8.25 size that I use. And then again, tapping movements to make sure that only your desmase membrane and part of the posterior stroma is inside. Once you do this, then again, the second round of staining with trypan blue. And then after you stain with trypan blue, then again, take off all the excess trypan blue so you can see what you're doing. And similarly, don't drop trypan blue or fluid directly on the surface of the endothelium, but do it in the periphery so you don't make sure that any of the endothelium is injured. Then take off the peripheral frill that you've excised now. And so the central part of the desmase you haven't touched so far. So you're touching it for the first time. So lift it up and fold it in a 60-40 configuration. This is where it's a little different from what Vikas showed you. And then ensure that you remove all the fluid from the opposite side so that the tissue is lying flat, endothelium to endothelium. Then I use a 3 mm punch after I've lifted this to ensure that I'm in the center. And I ensure that in case the punch hasn't cut through all the way the stroma, then I use a scissor to make sure that there are no adhesions, because if you have adhesions, you'll be in trouble later on when you're trying to mark. Then I put the cap back just like Vikas shared with you. And once this is done, then you drop little fluid and make sure that the tissue is lying flat again on the posterior stroma. Once this is done, then you take the tissue and reverse polarity and turn it around to the opposite side, take off the cap, and then keep it on the side so that you'll need it again. Very important to dry the surface, like Vikas said again, and then use your marker. You can use anything, and then make sure that you've got a very visible and distinct mark that you can identify inside the eye. It's important to dry it because otherwise your mark will smudge. And then put the cap back, because if you don't put the cap back later on when you're staining the tissue and the tissue is free, your tissue can float out through that hole in the 3 mm punched area, and also it can get stuck in between the flap. So that is the summary of tissue preparation that I use, and that's my technique. Certain small variations from what Vikas showed you, and probably the biggest difference is the fact that I tend to punch after I've done my second trepanation to ensure that my letter is in the periphery, and also it is within the second punch. But you can use either, whichever works for you. Thank you very much.
Thank you, Dr. Praveen, and that was beautifully explained in detail. I think we'll take up questions related to this after Dr. Rajesh's talk. Over to you, sir.
I think most of the points are what Vikas and Praveen have already mentioned in their talk. And we will straight away come into donor preparation. So you do the partial trephination in the periphery, free the edge, do the peeling. And once you have done the partial peel, go ahead, create the stromal window, flip it over, put in your stromal, marking of the stromal side of the DM, come back, do your second trephination, and then you peel off your donor, stain it with trypan glue. So again, like Sunita mentioned, that age is a criteria. So be careful when you choose your, if you get a tissue which is from an older donor, you have to be a little bit more careful because the elasticity is less and they tend to be more brittle. So when you hold with the forceps and you try to peel off, sometimes the tissue tends to break much more easily. It's like more brittle. So the peripheral trephination that you do, you can get these partial depth trefines like one from Moria or from Yanak, which have only 100 micron blade. So if you, no matter how hard you press, you will create only a peripheral break which is 100 microns thick. You can go to the periphery and identify the free edge of the decimates. It's important to free this at least 270 degrees, and the remaining part you can use it as your hinge. So if you do encounter a break somewhere, you can go in the reverse direction and keep that break in the area of the hinge so that you don't create any traction in that point. And it's important to stain multiple times using trypan glue so you can highlight the cut edge, because the decimates usually stains on the stromal side and not on the endothelial side. Using a forceps with a broad holding area gives you a better grip than a point forceps. So once I have done the partial peel about 60-70%, it's important that you should be able to visualize the decimates that you've already peeled, because these decimates can sometimes float back, and then when you're doing your 3 mm partial punch, you can end up breaking the decimates. So you can use either a 2 mm or a 3 mm punch. And as Praveen pointed out, the punch is sometimes not through and through. So you have to go and confirm. And if it is still not, then you flip it over. Marking, it's important. A lot of times the ink gets smudged. So what you can do is you can place the ink on your glove. You can mark the one surface of your back somewhere on the underside of the glove, and then you can apply the ink from that to your marking device. Important to dry the surface, then put in your stamp, and then close the, flip over the tissue, do your partial trephination again, and then your tissue is ready. The other way, if I have a younger donor, sometimes I do get younger donors, and there, if you do your trephination, it's sometimes difficult to find the edge because the decimates is more tightly adherent. So the variation there is, instead of using a trefine, just use a sharp number 15 blade, a 15 degree slit knife, and use the point to break the periphery, the decimates. So you're not cutting, you're using that pointed tip just to break the decimates. Once you have done that, you stain the peripheral DM and remove the tags, and then you can go with your hook and try to identify the cut edge. You will see a stain and a non-stained part. So there you go and you try to free the edge of the decimates, and rest of the peeling part is pretty much the same as what we did in the previous technique. Now this is what the schematic diagram represents. When you use a trefine, you get a nice smooth cut, but when you use the pointed tip of the blade to break the periphery, you can have ragged edges. Mind out, watch out for these radial tears. The advantage you have is when you use a trefine and if you cut a little deeper, sometimes it's very difficult to free the edge of the decimates, because every time you try to do that, the stroma also moves along with it. The advantage of using the breaking just the decimates using a pointed knife point is that you don't break the stroma, so it's easier to find the edge of the decimates. The other thing about staining between F, S, and a P, if you look at this diagram, you will realize that the surface area of an F stamp is lower than the surface area of a S or a P. So the smaller the surface area, I think the lesser amount of endothelial cells that you're going to kill. Now, this is something that I designed, and it's a prototype is designed, made by Network Medicals. It's still not under commercial production, but this is something that provides retro illumination so that when you are stripping your decimates, you can have a very good view, just like you do for your capsular axis. So here, you can identify any abnormal areas of adhesion, especially if you have a pseudophakic tissue. And also when you're peeling, you can see the edge much better throughout the point when you're dissecting. So that's in short about decimate donor preparation. The other thing is there's a recent paper that came out that looked at the speed of peeling and the amount of curl that the tissue had. They found that if you tend to strip too quickly, that means if your rate of peeling is much faster, you tend to have tighter scrolls. Whereas if you peel very slowly, your scroll will be wider. And that same thing has been shown in the DM donor preparation technique described by Donald Tan as well, where he uses his micro dissector to try and separate the adhesion of the decimates from the underlying stroma. And because there is no stretching of the decimates or the elastin associated with the decimate membrane, you don't get the tendency of the tissue to scroll that much.
Thank you, Dr. Rajesh. And that was some of the tips from Dr. Rajesh. I think there's a question which is coming up about the instrument you have used to handle the DM while stripping.
That's basically a DM stripping forceps. It has a wider area of gripping. You can use a curved tying forceps as well and use the curved area to hold a larger area of the decimates rather than just holding at one point, because then the focal pressure at that point on the decimates is much more. Frederick Cruz has described holding using two tying forces, but then again, coordination between the two hands is sometimes not symmetrical. So the asymmetrical pressure can itself result in tears in the decimates.
I think we'll go on to the next talk now. Thank you, Dr. Rajesh. And it will be about transition from DSEK to TMEK. We have Dr. Bhaskar Srinivasan. He is the cornea consultant and external diseases, Shankanetrale, Chennai. Over to you, Dr. Bhaskar.
Yeah. Good evening, everyone. Am I audible?
It's very clear, Dr. Bhaskar. Please go ahead.
Sure. So thanks, Nidhi, for the invite. So my talk is on transition to DMEK. No financial interests here. So Dr. Rajesh has already mentioned as to why we need to shift to DMEK. There is a definite faster visual rehabilitation. The incision that we make is smaller. The visual results are better. And the cost, when you compare a DMEK with a DSEK, it's probably much less expensive in DMEK as compared to DSEK because we don't need specialized equipment. However, there are barriers that we as surgeons need to cross. When we shift from
Bhaskar, sorry to interrupt. I think you need to do the full view of your slide. It will be better if we have the full view. Yeah, thank you.
So there are barriers that we need to cross. DMEK involves learning new skills. So the two main bugbears in DMEK is tissue preparation, because we are always worried that there would be tissue damage when we prepare the tissue. And the second would be tissue insertion, where we are worried that traumatic unfolding of the tissue would lead to a primary graft failure. And these are skill sets that we need to acquire. It takes extra time to learn any new surgery. Same goes for DMEK. There is a steep learning curve, and there are studies which say you might need about 50 or 100 cases before you're as comfortable doing DMEK as you would have done a DSEK. And there's a relative inertia. When we are so comfortable with the outcomes with DSEK, we feel, why do we need to shift to DMEK? But the advantages that we've already mentioned make it imperative that we need to change and move on to DMEK in certain situations. So the fact that you have attended this webinar itself tells that you have decided that you want to learn it. So then you need to read up everything which is available in literature on DMEK. You now have surgical videos across in YouTubes. You have it shared in various WhatsApp groups. Try to go through each surgical video as much as possible. Attend DMEK courses in conferences. Attend wet lab in conferences. You also have specialized DMEK courses conducted in India and abroad. And these are more focused, a couple of days or a week's course, where you are able to meet and interact with the preoperative patients, the operative patients, and you're able to see a vast number of surgeries being done in a short span of time. That gives you the confidence that yes, this surgery is something that you would want to do. And of course, attending webinars like this would make you much more comfortable going ahead with DMEK. So plan of action would be to first have a wet lab where you would understand what it involves, and you could use any discarded poor quality corneal tissue, and you can try preparation of the donor tissue, as has already been clearly described by the previous speakers. The other one, which Vikas was mentioning, is quite interesting, because if you don't have access to a donor cornea, you could still use onion as a source, and you trepine about 18 to 20 millimeters of the onion first. So that acts as a donor corneal scleral rim. And then you try to peel off the innermost layer. And the characteristic seems to be similar to DM, because it scrolls in a similar manner. And that could be useful for you to get a feel of the tissue. The next part would be how to do the injecting and how to unfold the tissue. So if you use a normal artificial chamber, because of the concavity, the tissue kind of sinks below, and it's very difficult to unfold it. So people have advocated using some kind of a diaphragm, using either a plastic sheet with or without a hole, or a latex drape that is basically cut off from your gloves, which can act as an artificial iris. And with this, you can actually titrate the chamber depth, making it deeper or making it shallower, and play around when you're working out in the wet lab to get your DMEK or your tissue orientation appropriate. You could also use whole globes or porcine globes, but generally these are more hypotonic and the cornea is quite edematous, so it might be very difficult for you to unfold it in those. So the artificial anterior chamber serves as a useful tool to practice the entire unfolding in your wet lab. This is a picture where they have marked the center of the cornea to make sure that your pupillary opening, it simulates your pupillary opening, and almost the entire process of unfolding can be done there. If your cornea is quite edematous, you could use glycerin to improve visibility. The use of a light colored gloves facilitates a better contrast between the blue stained Descemet's scroll and the underlying glove color. But before you start your first case, if possible, you've learned the technique from somebody, you can actually invite the concerned person maybe for a conference, and he could be there to handhold you during your first cases. You could record, or you should record all your videos, because if you end up with a problem, it's good to go back and review the videos so that you realize where you went wrong and correct them in your next surgeries. If you have your first case, always better to have a backup of donor tissues, but don't keep the pair of the same eye. As was mentioned by Dr. Sunita, that similar tissues behave, both the eyes of the same donor almost behave similarly. So if you have had a problem stripping the Descemet's membrane from one pair, you will have a similar problem in the second donor of that eye. Always prepare the tissue first so that you're comfortable and you can go ahead with the rest of the procedures in the patient. And ideally, you should not have a long OT list on that day, because when you're starting off, you don't want too much of tension with a lot of waiting patients on that day. Last but not the least, you need to be judicious when you select your first patient. An ideal patient would be a pseudophakic fuchs. Don't select one-eyed patients. Don't select a type A personality. We do explain the possibility of rebubbling to the patient, because it's higher in DMEK as compared to DSEK, at least in your initial cases. And with that, I think you would be set to go and transition from DSEK to DMEK. Thank you.
I think Dr. Bhaskar, after your wonderful talk, there will be a lot of sale of onion tomorrow by all the...
I think Vikas needs to get the
article on the...
Yes,
on
Vikas
the
needs to be
onion.
candidate for the onion sale and the increase in price.
Yeah, Dr. Vikrant, I think people will be look out for that article.
We have already published that article. That's already published in Cornea.
I think that's a cause for increasing prices of onion in North India.
With that onion sale, I think we'll go on to the next talk by Dr. Audrey. Dr. Audrey.
Nidhi, I have one question. Nidhi, I have one question before I leave. Just one query. Vikas can answer that also. Lehman, which marker pen do you use for a marking? As you rightly said, GB is not a good idea because that's too toxic.
Sir, we use gentian violet only. We had used the methylene also, but I think that was causing more edema. So for the time being, we are using gentian violet only, the one that we get with the toric IOL marker.
We routinely use, biscuit pen, which is, I think, the safest one.
Okay. So what does it have, sir?
I'm not sure, but it is a ink only, which is much
Yes.
safer.
Okay.
What about Parveen?
It's gentian violet only, the viscot marker. It's water-based rather than alcohol-based.
Yeah.
So once marked, it's very important to ensure that the alcohol or the water dries out completely, and then just put the stamp on. So then that way it becomes.
Thank you.
Thank you, Dr. Tyal. We'll go on to Dr. Audrey. Dr. Audrey is the Director for Cornea Services at Northwest Eye Institute at Seattle. Dr. Audrey, good morning, and please go ahead.
Great, thank you so much, and thank you so much for the invitation. I am going to be speaking on DMEK patient selection, my financial disclosures, none of which are relevant. When we discuss patient selection in DMEK, we want to know a few things, the main indications, relevant signs and symptoms to look for, and of course, counseling for the patients. Consideration for DMEK include young patients, phakic patients. What's really mission critical here is you want to be sure that you have a good view. Unlike DSEK, where you could really basically do it by feel almost, you need to have a good view, especially when starting DMEK, because if you don't have a good view, you're not going to be able to proceed with the unfolding. Ideally, your first patients would be minimal coexisting morbidity, and you can also try it with a failed DSEK. Isolated endothelial failure, simpler patients, I know which there aren't very, very many in India. Most of the ones I see are very complex. However, if you do have a patient with isolated endothelial failure from Fuchs or pseudophakic corneal edema or eye syndrome, these would be your ideal patients to start with. Again, you want minimal stromal edema because the thing that's mission critical for DMEK patient selection is the ability to see. Patient with a multifocal IOL or a failed DSEK graft can also be ideal first patients. More challenging patients if you do have someone who has a deeper anterior chamber, because as was demonstrated, you really want to be sure that you can shallow the chamber. So if you have a larger, deeper anterior chamber, such as someone with a previous vitrectomy or a high myope, these are going to be more challenging for you for your first cases. Prior glaucoma surgery as well. If there's a tube shunt or a trabeculectomy, you have to be careful because the DMEK graft, as you're tapping and unfolding, can actually go and start to go through or into where your tube shunt is. Not that I've ever seen that happen before, but you have to be careful there. Moderate to large iridectomies also require very awareness of this and are much more challenging. Also, trying to do a case where you have to do a DMEK only at first, or maybe a DMEK combined with a cataract rather than an IOL exchange is also going to be a good first patient. And a patient with a prior PK, a prior keratoplasty, is also someone that's a really good candidate, but is a little challenging, I would say, for your first patient. How do you decide to do a repeat PK or DSEK versus the DMEK? You want to see what was the previous vision before the graft failure or in the contralateral eye. And so if you have someone where there was very poor vision prior to graft failure, then rather than using a DMEK tissue, you may just consider doing a repeat or a DSEK on that patient. If the patient has a lot of astigmatism, previous PK, but has a lot of astigmatism and irregular cornea, that may be someone where you just want to repeat the PK because if you have a very irregular cornea, the DMEK graft won't help you necessarily there. Anatomic factors, again, if there's corneal scarring, if you can't see through the cornea, you're not going to be able to do the DMEK. And so when you're looking at patient selection, you really want to be sure that this is someone who you're going to have a good view. If they don't have a good view, then the DMEK, I would say, would not be wise. A lot of PASS as well. That's going to be another very, very big challenge for you, especially with the unfolding. You probably are going to be better off doing a DSEK in the case of a lot of PASS versus a DMEK. Contraindications. If there's too large an iridectomy, if it's very, very large, you don't have a lot of iris there, even DSEK can be challenging in terms of not losing the graft. If you have a very, very large iridectomy and you're trying to do a DMEK, there's a higher chance, especially with the tapping and the unfolding, that you can in fact lose the graft and it can go down to the retina, which is obviously not ideal. If you have partial or complete aniridia, again, these are patients where I would really highly recommend that you don't do a DMEK. Aphakia, if you do have a patient, however, who is aphakic and they have a good amount of iris there, then you can in fact consider a DMEK in that patient a little bit more advanced. However, if they're aphakic, as usually with aphakic patients in aphakia, you're also going to have big iris defects. I would not recommend. A patient with an ACIOL, you probably are going to be better off doing a DSEK in that patient rather than the DMEK. Again, because when you're tapping and unfolding, you don't want to tap and unfold the graft against the ACIOL. And also, if there's a glaucoma implant in the anterior chamber, this is someone where you want to either make sure that you place the glaucoma implant, you remove the glaucoma implant and place it posterior to the iris, or if it's a tube shunt, you can cut the tube shunt, but that's definitely more challenging. A perfect case history would be a patient, this patient, gentleman who's a 58-year-old with a corneal dystrophy and a cataract. We have a no prior ocular history. Exam is 2040, 2070, and a moderate nuclear sclerosis. Corneal pachymetry was 590 microns in the right eye and 650 in the left eye. And for this type of patient, although there is absolute, no absolute, as we know, as to who makes a good candidate in terms of corneal pachymetry I find is good to follow the patient along. On the basis of just a single pachymetry reading, of course, if their normal pachymetry was 460 and now, it's 520, that's different, say, than someone who was a 540 pachymetry and then has gone to 590. So pachymetry alone will not tell you, but it is useful to follow along. Why do DMEK? Well, of course, has been pointed out, post-DMEK rejection rates are lower than DSEK. Looking at this article, and this was from 2012 in ophthalmology, DMEK, the rejection rates are really about 1%, DSEK 8 to 12%, and PK, of course, higher than that. In my own practice, I have found also where the rejection rate also of about just about 1 to 2%. DMEK results, of course, better vision, quicker recovery, less rejection, and better endothelial cell retention. The one thing that you want to warn the patient of is that, especially at first, you will have a higher rebubbling rate than with your DSEK. And so definitely a higher rebubbling rate. However, I think once you're through your first maybe 20 or so cases, your rebubbling rate gets a lot lower. But that is something for the patient to be aware of. This is another article in ophthalmology looking at outcomes of consecutive cases. And again, there's a lot better vision. You're going to get better vision more quickly. Of course, we know with DSEK, you can get that good vision, but it can take 2 to 3 years for you to get your 20/20s and your 20/25s. And with DMEK, you're going to find that that comes a lot sooner. another article here, AJO. These are some older articles, of course, looking at retrospective cases. This one I liked because it looked at patients who had DSEK in one eye and DMEK later in the fellow eye, and looking at patient satisfaction. And again, satisfaction was definitely better for the DMEK. Why? Because they had a quicker vision recovery, and you're going to get your vision of 6/6 a lot sooner. And with that, I wanted to thank you. We can see some good friends here in the photos, and wanted to thank you so much for this opportunity to present.
Thank you, Dr. Audrey. I think there are a lot of people who are just getting to learn on DMEK, especially on this course. Dr. Umang, do you think that there would be some pointers you would like to give for the ideal cases they should pick up for once they're beginning to do DMEK?
Thank you, Dr. Audrey, and thank you for joining in very early morning for you. Thanks for waking up early for us.
Of course.
And well, I think Dr. Audrey has already mentioned, I think you need your clean cases as your first cases. I think the most important is that you should have good visibility. You can't have a case where it's too hazy, your cornea is too edematous. I think I wouldn't take that up as my initial case. Relatively clean cases, dilate and check whether the lens is in the bag. You don't want irregular anterior chambers, peripheral anterior synecdoche, cases which have had glaucoma surgeries. I think essentially you like a clean case where you just have endothelial problems and the rest of the anterior chamber, the pupil is round, and you don't want other problems with it. I think very critical would be to have an eye which has good visibility. Now, the only rider is that sometimes after removal of the epithelium, the cornea becomes reasonably clean. So in such cases where you are not sure, a tip I learned from James was that you debride the epithelium in the outpatient's clinic and then check how the visibility is. So you could, in the pre-op time as well, remove the epithelium and see how the visibility is to decide whether you could take it up for DMEK. Because sometimes just removing the edematous epithelium clears the view quite a bit.
The other thing I would add is that also sometimes with a failed DSEK graft, is that once you move that failed DSEK graft, your vision also improves dramatically.
Right. That's correct.
Yeah. Here I would like to invite Dr. Basak has joined us. Dr. Basak is the director for Drishti Eye Hospital in Calcutta. Doesn't require any introduction. Good evening, Dr. Basak. Are you with us?
Hello.
Yes, Dr. Basak, we can hear you.
Yes. A very lovely talk by Bikash, then Probin, Rajesh, then Audrey and Bhaskar, and nice learning process is going on.
I think there are a lot of trainees here, a lot of attendees who want to know your pointers for what would be the difficulties they should expect as beginners for the first few cases, what they should be keeping.
I think the importance of learning DSEK first, I mean, you must learn the rescue first, because first few cases, there might be every possibility you may lose the graft at any point of time, being during donor preparation or during unfolding. During PI, a lot of bleeding happens sometimes that actually kills the surgery. So you must do at least, to my mind, at least 50 DSEK, good DSEK. You must be very much comfortable with your DSEK surgery. Then after doing whatever has told by Bikash and Bhaskar, then wet lab and learning from the master, going to their OR. Because we see most of the time edited video, but if you see the surgeon physically, spend with him or her for 2 to 3 surgeries consecutively, and you will learn a lot of tips. Position of hand, position of your elbow, position of your finger, instrumentation, everything matters for donor preparation and also unfolding of the donor graft. So at this point of time, I want to mention, I must thank Shrunita to bring out that thing, that peripheral DMEK tissue. I prefer that because now I am very much convinced, and recently I have compared my 300 with peripheral, with 300 with central DMEK, and peripheral eccentric graft is much, much higher, giving value at least 150 to 200 cell at the end of 1 year or 2 years. So the range is more than maybe 5 to 7% in these cases. So if it is eccentric, don't worry. I mean, it is advantageous. I always say that if you are not central for DMEK, it is better.
Okay, I think the time is shooting up. We'll go on to Dr. James. He'll be talking about his technique of perfect DMEK. Dr. James is the cornea consultant at Focal Point Vision and associate instructor with University of Texas at San Antonio, and we have had him at shop, and he's an excellent surgeon. Over to you, Dr. Lehman.
Thank you. Can you hear me clearly?
Hi, Lehman.
Perfect.
Hi, everybody. Hi, thank you for having me. So I was given the topic of speaking about the perfect DMEK. Here are my disclosures, none relevant. I primarily do DMEK in my clinic, about 70%. And I just want to thank my friends at Schroff's. I had the opportunity to do a DSEC skills transfer there in 2018, and here's a photo from there. And of course, also like to thank Dr. Umang and Dr. Nidhi. So perfect is kind of a loaded word. It means being entirely without fault or defect. We use it all the time, but I think all of us would hesitate to describe our surgery as perfect. So I found this quote by Vince Lombardi. He was a football coach in the United States, and he said, perfection is not attainable, but if we chase perfection, we can catch excellence. And so that's going to be the theme of my 10-minute talk here. So we're chasing perfection, but we're really just trying to become better. And this is what we're shooting for. We want a cornea that's clear on the first post-op day like that. And to get that kind of result, you have to set yourself up for success. And that begins with patient selection, using quality tissue, and most importantly, continuous improvement in your surgical steps. And so as Audrey was talking about, patient selection impacts success. And when you first begin with DMEK, this pain scale there is not patient pain, it's doctor pain. And you can make your life hard if you choose difficult cases. And so what are difficult? Like the previous speakers have said, the complexity of the anterior chamber, PAS, previous angle closure, small eyes, vitreous prolapse, ACIOLs. These patients require probably DSEK until you become comfortable with doing DMEK in more complex eyes. As Umang was saying, corneal clarity is very important. And in the clinic, you can do an SK the day before to kind of see how good the view would be. As Audrey said, bubble management is critical. If there are iris defects, PAS, if there's hypotony, all of these are difficult to manage the bubble and make the case more difficult. Lens status, avoid combined cases in the beginning, and previous vitrectomies or unicameral eye are much more difficult to maintain a bubble or to collapse the anterior chamber. I also recommend preoperative anterior OCT if you don't have a good idea about what the anterior segment looks like, because it can shed light on the complexity of the AC. So here's some pictures of patients that aren't good DMEK. The two on top, I would recommend doing an IOL exchange first, either sutured or Yamani, and then coming back a month later or so to do DMEK or DSEK, depending on your comfort level. On the lower left, that patient probably requires a PK, unless you can remove that scar, which sometimes can be done. And in an aphakic eye with no iris, I would recommend DSEK with a rescue suture. In terms of DMEK tissue, we kind of have gone over this already. For me, the most important thing is we have to order our tissue. So I measure the corneal diameter in all my patients to choose the appropriate graft size. Because if it's a small eye and you choose a large graft, you can't get it to unfold. Additionally, I always like to look at the picture and make sure that the cell count corresponds to the photo. So now I'm going to talk about the continuous improvement in surgical steps. So this begins even in the first steps when you're going to just mark the cornea. I like to use an 8mm trephine. That's kind of my default, and mark the central cornea, geometric center of the cornea, and also make sure there's enough space on the periphery to make nice incisions that don't impinge on the area of the graft. I place traction sutures for my cases in case I have to rotate the eye, because my technique involves centering the graft last. In terms of making incisions, this is a combined case, and I'm making the incisions here both temporally. I make 2 paracenteses, inferior temporally and superior temporally, and here I'm injecting vision blue because I'm going to be doing the cataract part, and I also wanted to illustrate the length of the tunnels of the incisions. So once I rinse this out, you can see that the length of the tunnel doesn't impinge on the area where the graft is going to be, and that's very important, because if you use those paracenteses to inject air, you would inject it in the interface instead of into the anterior chamber. If I'm doing phaco, I do a 2.6 millimeter incision. If it's just a DMEK alone, then I would do about a 2.2 incision. Removal of the desmetorrhexis. This is a step that's pretty hard for novice DSEK and DMEK surgeons, and you'll notice that I go around 2 times here with moderate pressure. Novice surgeons tend to use too much pressure, and you'll see them starting and stopping, and that tells you that you're using too much pressure if you can't do it in a continuous circle. Also, you'll see more whitening of the cornea. I'm doing this removal under Helon because I'm doing a cataract too, but it can be done under air or under an AC maintainer. I feel the easiest is under Helon, and with this nice red reflex, it makes it very easy to see Descemet's membrane. If you remove it, but not all of Descemet's has been removed and there's tags, there's 2 things you can do to see those tags. One is to inject air in spite of having Helon in the AC, and that'll show some areas. And also you could remove the Helon and inject trypan blue. That will show any kind of tags that you have. So in terms of the surgical steps, every surgeon does things a little differently, but the basic 3 things in common are injecting the tissue, positioning the graft, and then placing an air bubble. And so I've evolved to use the goiter glass cannula. We receive this already pre-stained, and I feel like it keeps the chamber the best. I used to use an IOL injector, and I feel like the glass cannula is kind of the way to go. In terms of positioning the graft, I'll show you my technique, but basically I flip and unroll the tissue until I can confirm the orientation, and then I unfold it using a small air bubble and then center it. So here's a technique of flipping the graft if it's upside down. So I'm going to show that in slow motion. We flip the graft by injecting fluid underneath the graft, and that creates a fluid wave in the AC that flips it 180 degrees. So that's a very critical step to learn, especially if you have an S stamp and you see that the S is upside down. In terms of unrolling it, there's 2 ways to do it. You can collapse the AC and tap it, which is the most common thing, and is being shown here. You can see I don't use an S stamp, and I'll get to that in a second. But that's the most common way, is to collapse the AC and then tap the graft to open it. However, you can release aqueous, okay? So here I'm injecting through a paracentesis and then going through my main wound, and you see the egress of fluid through the main wound causes the graft to open a little bit, like a bouquet of flowers that you can then tap to further open. And there I'm trying to get that hat formation. So when I started doing DMEK, we didn't have an S stamp, and I'm still kind of doing it that way, but we want to get this orientation of the tricorn hat. And so this will confirm that the roll is in the correct orientation. And so then what I do is I use a flashlight in the OR, and I shine, and I want to get 2 rolls like that. And so once I have orientation correct, then I go in with a 30 gauge needle, and I just insert a small air bubble underneath the graft. Again, in slow motion here, with the chamber pretty small, you go in, you go under the graft between the IOL and the tissue, and you inject a small air bubble. This allows a lot of flexibility and technique, and you can do this in eyes that have been previously vitrectomized, because the air bubble helps you to unroll it and you don't have to collapse the AC so much. So we'll move on. And so once the bubble's under there, then I want to unfold the graft. And you can do that by creating space and using the momentum of the bubble to get that roll undone. And here's another example, rotating the eye a little bit and then touching on that point fold, using the momentum of the bubble to kind of unfold the graft. Notice the graft isn't centered. So I unroll it or unfold it, and then I center the graft. And so here, when I center the graft, I'm knocking out that little fold. When I center the graft, what I'm doing is doing little golf swings, or cricket swings, you could say as well, but not so vicious. You're just gonna kind of tap it and bring it center. The key thing here is to rotate the eye so that the graft is going downhill, and also so that the bubble is always under the graft, so the bubble doesn't sneak around and get on top. And so I use the marks that I had at the beginning of the case, and I center the graft that way. So that's nice and centered. And then the final step is to inject a big air bubble. And so here I'm going back through my paracentesis, and I'm going to join up with my bubble. And if I'm able to get good moderate pressure in the eye, that's all I need to do. But if not, I'd supplement the air through the paracentesis right there. So in terms of chasing perfection, I found this case, and I had some good steps in it. So I'm going to show there. I'm getting the graft ready. I'm going to inject it, and I'm doing a small incision here because I didn't do the phaco. So it's a 2-2 incision. So kind of a snug fit. Inject the tissue in, then placing the suture. The critical thing here is just making sure the graft doesn't shoot out when you're trying to suture up the wound. So then I'm going to use bursts of fluid to try to get it to unfold and get in that tricorn hat. And what I'm doing is trying to get in a good position and then trap it by collapsing the anterior chamber. I didn't like that, so I'm flipping it over. And now I'm going to tap it to try to open it. And it likes to open nicely there. And then I'm using my light to verify the orientation, seeing 2 scrolls, and then going in with a small air bubble underneath. I'm injecting just about 0.4 cc's of air in there. And then the hard part's over now. And so what I'm going to do is tap out that fold. And then I need to tap that fold out, but it's not coming. So I want to use the motion of the bubble to help me. So I'm going to rotate the eye and use the uphill motion of that bubble to unroll the fold there. Now I'm just going to use some golf swings to center it. It looks like it has to go inferiorly a little. Now a little inferior. And then we're done. And so I'm going to put in a bigger air bubble right now. And then I didn't like the pressure, so I'm going back through my paracentesis and injecting a little bit more. So now I have moderate pressure, which is what I like. And in this case, I put in a steroid implant into the punctum there to help just with inflammation post-op. And so that's my last slide. I like to climb mountains. And in the mountain business, we say the summit is for the ego, but the climb is for the soul. And in surgery, perfection is for the ego, but the pursuit of perfection is for the soul. And that's what counts. So I want to thank you for your attention, and I'll turn it back over to Nidhi. Thank you very much.
Thank you, Dr. James. That looked like a perfect DMEK. I think we have a lot of questions about what would be the perfect way of doing DM stripping. Would it be under air or an AC maintainer? What is your preference? And does that change with the type of patient we are dealing with?
Well, there's two situations. I like to do it under viscoelastic, but viscoelastic is expensive. And so if you don't have that ability, then you can do it under an AC maintainer or air. However, if it's PBK, you can inject Vision Blue or Trypan Blue into the anterior chamber, and it'll stain the dead cells. And that really helps with visualization. But if it's a Fuchs patient, you don't get stain when you put in the Trypan Blue. So my recommendation, if you're learning DMEK and you have viscoelastic available, is to do it under a cohesive viscoelastic that you can easily remove at the end of the case. But like I said, many skilled surgeons that I've watched are able to do it under air alone without the air escaping from the eye. So it's in the beginning, I think Helon is the best.
With that, we go ahead with the webinar, and we'll be going after the perfect DMEK with some tips by Dr. Praveen on wound creation in DMEK.
Thanks, Nidhi, and wonderful presentation, Dr. Lehman. Difficult to follow a perfect DMEK with some imperfect ones. But what I thought I'd share is some of the things that I've learned along the way about making incisions in DMEK. And the reason why I thought this was important is because most surgeons who are used to using DSEK, doing DSEK, tend to make very long incisions in DSEK surgery, which is sort of preferable so that you can have an overlap between the internal lip of the wound and the graft that you put inside the eye. So longer incisions are desirable in DSEK surgery. So these are videos which are relatively old, and they're all from DSEK cases. And you'll also see that when making the incisions in the DSEK eye, you tend to keep the eye a little softer so you can get a longer tunnel, which you can overlap with the graft as well to get a hermetic seal, and you don't need to put sutures in eyes like this. But when it comes to DMEK, just like Dr. Lehman mentioned, one of the most important things to do here is to ensure that you have a very short incision. And you also need to angulate your incision downwards towards the iris and not go towards the center of the pupil. This will allow you to make sure that, like Dr. Deepan said, you don't have an overlap with your graft as well. And by default, I use a temporal incision, which again keeps your internal lip further away from your graft margin, and also a shorter tunnel, which you also are sure that this will not overlap with the graft. And the other issue with the main incision is the fact that if you tend to depress your main incision accidentally, like you'll see a little later, the graft will tend to extrude from this area. So you'd rather have it further away from where the graft is positioned at the end. The third incision, typically I tend to make two side ports, and then after you finish with the Descemet's membrane stripping, I tend to fill up the anterior chamber with air and then make another incision for my PI. There were some questions about making a PI. The methods differ. You can make a PI before surgery, you can make a PI during surgery, but what I prefer is to make a stab incision inferiorly at the limbus or just beyond the limbus after I finish my Descemet stripping. Enlarge it slightly so that it gives you access to fine forceps, so you can go inside the eye. And once that is done, I take out all the air from the eye so that the anterior chamber is relatively shallow and I have access to the peripheral iris. Pull it out with a non-tooth forceps and cut it horizontally to get a broader PI. Wash out all the blood that might be inside, and you can check the patency of your PI by inserting an instrument behind the iris. And only once this is done, it's important to go and hydrate the incision so you don't lose visibility. Once this is done, again, very important to put air inside your anterior chamber so that the blood that is present in this area, which invariably tends to seep inside the eye, is kept out of the anterior chamber. You don't have to deal with clotted blood later on when you put your graft inside the eye. The other interesting scenario that is relatively common in eyes that are inflamed and have had edema for a long time. This is a patient with a failed detached DSEK that I'm trying to remove the epithelium to improve visibility, but you'll see that the amount of bleeding on the surface is so much that your visibility goes down and you run the risk of this blood tracking inside the eye, which again makes things very complicated if the blood is inside the eye at the same time that your graft is inside the eye. So when this happens and consistently, if the blood is not stopping after a long time, what is important to do is ensure that your anterior chamber is either full of air at all times, or you have an anterior chamber maintainer that keeps washing out blood as it tends to seep inside the eye. And this will ensure that you get a good outcome without any blood inside the anterior chamber. The other tip that is useful is, again, if you have blood that continues to, vessels that continue to bleed, as you can see in the side port that is there at approximately 1 o'clock, though an air bubble can work and temporarily tamponade the blood vessels, but if there's continuous seepage, and you can see some of the blood tracking inside the eye as well, what is useful is to make a little small piece from your Vexel sponge and keep it in the area where you have your bleeder from. This will ensure that the Vexel sponge sucks the blood out from the bleeder and does not allow it to enter inside the anterior chamber. This will allow you to continue the rest of your surgery without any issues, and you can focus on what is really important rather than focusing on preventing the blood from going inside the anterior chamber. So that's the end of surgery, and you'll see that it is relatively clean. There's no subconch hemorrhage, which means that you've ensured that most of the blood is taken out by the sponge that you placed inside the eye. The other important thing about the incisions is the fact that when you are having an incision that probably is not very good, or you have a shallow anterior chamber, you might need to use an anterior chamber maintainer to deliver your graft inside the eye. You need to be very careful when you do this to ensure that there is no extrusion. But then again, also ensure that your graft is not in the same orientation of the incision after you put it inside the eye. Once you change orientation so that it is more perpendicular, your graft is generally safer. But especially when you're starting out DMEK surgeries, it is important that you suture your incisions, because especially your main incision, because if you see what will happen here is as soon as I depress the main incision, the graft starts to track and tries to exit the eye. So very important to also suture your incisions, because like I said right in the beginning, the incisions are generally shorter than most phaco incisions, so they probably would not be very stable. As you become more and more confident with DMEK surgery, you need not suture your incisions, or you can take off the suture at the end of surgery. So to summarize what we spoke about, it's important to keep incisions short. Also make sure that your incisions are crisp and use new blades or knives for your incisions, because if your incision tends to gape, then you will have a leak of air from your incisions, and then you'll have trouble forming your anterior chamber. About the peripheral iridotomy, there's a lot of difference in opinion about the timing. You can do it before or after surgery. Location, it probably doesn't matter where you make it. But if you're going to leave a complete air bubble at the end of surgery, it probably is better that you have a PI in place so you don't have a pupillary block. The reason I make an inferior incision to make the PI is I also have an access incision to release air if I feel that there's a pupillary block it's imminent when I see the patient a couple of hours after surgery. Surface bleed, always make sure there's air inside the eye, or use an AC maintainer to wash out blood, or like I showed, make a small Wexel sponge bait and place it in the air that you have bleeding from. And incisions, try and suture your main tunnel initially. Make sure that you don't suture it too tight, that you change the configuration or the shape of the cornea, which is again going to make it difficult for you to unfold and attach the graft inside the eye. The side ports, usually keep them unsutured right till the end, because again, you'll need to access the side ports intermittently during surgery. So thank you very much.
Dr. Praveen, does it make sense to do a YAC PI just at the time you're posting your patient or sending him for counseling for DMEK, especially in cases where you have a preferably clear cornea like a Fuchs patient?
Well, those kind of patients, at least in our scenario, are few and far between. So I wish we had more of them, but whenever I have a clear cornea, I just tend to send them and do the PI in the OR, just as a matter of practice. And I do it the same way in every case. And again, like I said, I like to have the inferior access incision to make the PI so that I can also depress that incision if I need to remove some air from the anterior chamber if there is a pupillary block developing.
And there's one more question that, is there any role of brimonidine eye drops to prevent the surface bleeding in these patients?
Certainly. Beginning of surgery, you can. And the other thing that I found useful is if I'm scheduling a patient for DMEK, I also start them on topical steroids about a week before surgery. It also reduces the inflammation inside the eye. Eyes that have had edema for a really long time tend to have more fibrin exudation inside the eye as well. It also reduces the bleeding on the surface and also makes the surgery more comfortable. Topical brimonidine, I use a drop if an eye is inflamed and is PBK before surgery, but it doesn't reduce the bleeding completely, and you can still have bleeders intraoperatively as well.
Thank you, Dr. Praveen. We'll go on to the next talk with Dr. Sunita. She will be covering her pearls about the DM stripping. There's a lot of discussion on the group about DM stripping. Over to you, Dr. Sunita.
Thank you, Nidhi and Dr. Praveen. Yeah. So DM stripping. Now, yes, if we have done DSEC, we already know about it, and but there are some differences in DSEC versus DMEK and how we strip and sizing related things. So there's some difference between DSEC and DMEK with regard to Descemet's membrane stripping in the recipient. So I'll be covering this talk under 4 relevant points which are related to recipient DM stripping. First is about maintaining the anterior chamber, the technique of stripping the Descemet's membrane, the sizing of the stripping, and the other related issues which are related to the posterior stromal irregularities, which, as everybody was pointing out, our cases are not always Fuchs. So we have more of non-Fuchs cases, and this becomes very relevant to address the posterior stromal irregularities during DM stripping in non-Fuchs signs. Now, this Nidhi survey was quite interesting, and I think it was very nice to see this. And this was the responses from the survey where we saw that majority prefer under air and some prefer under viscoelastic, some prefer under AC, nearly kind of almost similar comparisons between all of these. Now, there are many ways of doing things, as Dr. Lehman also pointed out, everybody pointed out that there are differences and one needs to know in what situation you would use which technique. All of these can be done, and it's good to be familiar with all of these because they all come in handy in specific situations. But There can be no one way, all ways are good, and you just have to see what works best in our hands. But yes, there are certain specific preoperative factors which will determine which kind of cases you can use air AC maintainer versus viscoelastic. Now, air is a good option because it gives a good contrast for stripping of the Descemet's membrane, and preferable for those eyes where you have a deep AC, so you don't have a proper, you have a good maintained anterior chamber with air. There's no issue of chamber collapse in these cases. Now, my personal preference for majority of the cases is to do the DM stripping under viscoelastic. This is specifically so for the cases where we are doing a combined surgery with a cataract, because we anyway are going to use viscoelastic, and we perform descemetorexis after the IOL insertion step. There are other cases, as we already pointed out, like majority of the indications in Indian eyes tends to be pseudophakic corneal edema. Patients who have got synechiae, distorted iris, and shallow AC is also one of the preoperative reasons where it is better to use a viscoelastic because you get a much better control. It avoids chamber fluctuations. Now, if you have a lot of chamber instability while stripping of the Descemet's membrane, you can cause iris prolapse in the cycle, which is not a good thing to have. And it also makes the iris little floppy. So I think it is best to avoid the situation so that subsequent steps become easier. Also, if you have AC instability while stripping of the Descemet's membrane, there is a chance that if there is a peripheral PI in those cases, in those complex eyes where the lens is subluxated, iris lens diaphragm is not very stable, these cases we can have a vitreous prolapse, especially those with open capsules also. So I think it is important to assess the chamber stability before determining what works best, and in most of the PBK cases, viscoelastic is a good option. About retaining the viscoelastic, I think we just wash it thoroughly, and thereafter the timing of doing PI would be is usually after doing the DM stripping, and thereafter when we do the PI, we are using obviously a fluid maintainer and under the vitrector. So this also helps in clearing of the retained viscoelastic. So there's not much of a concern with using viscoelastic either. And yes, as already pointed out, AC maintainer is also a good option. The technique of DM stripping is pretty much similar like what we do for DSEC. I didn't have it, but the technique is quite similar. We just indent into the Descemet's membrane. This was a previous case. I didn't have I did a video of the same, but it's like we score it opposite to the side where we make the paracentesis and strip it gradually from the edges to the center and then pull it off. We may make a circular mark, but circular mark interferes with the visibility of the Descemet's membrane, so it is better to put dots as Dr. Lehman had shown in his presentation. In many cases, we may have to remove the epithelium while marking just for a centration. So it's in cases where the epithelial edema is there, we have to remove the epithelium. Generally, the sizing is around 8 to 8.25 millimeters, and this should be slightly larger than the size of the graft itself. Now, why this is so is because eliminating an overlap of the graft with the recipient Descemet's membrane facilitates the attachment of the graft. So this particular aspect is important for DMEK, not so much relevant for DSEC, where you can even do a non-stripping DSEC. What about the posterior stromal bed irregularities? Now, there are certain situations where we may encounter loose irregular tags. These occurs in cases where we have a Descemet's membrane scarring, quite often seen in cases of PBK, complex cataract surgery. These need to be removed with forceps, especially so because in these areas where there are loose tags, there can be a focal detachment, so the Descemet's membrane attachment will not be very good. And one specific way of highlighting these loose tags is by staining with the trypan blue. Vitrector may be needed in some cases where there's a thick scar DM, and some of the cases with bad pseudophakia come with a thickened Descemet's membrane, where it may not be easy to peel off the Descemet's membrane, and we may have to use a vitrector to make the posterior bed little regular. Now, this was one case where you can see that the posterior stroma shows a very thick, dense Descemet's. There was a DM detachment probably, and there was a DM which was coiling onto one on top of the other, and there's some bit of scarring which is seen well on the OCT. Now, this membrane was very difficult to peel, and we had to use a vitrector to have a regular posterior stromal bed. Now, there's one specific point related to posterior polymorphous corneal dystrophy. Now, here we see the thickening of the Descemet's membrane, and there's a double rail track sign. But in these cases where you are peeling of the Descemet's membrane, you also encounter loose stromal tags. So it is important to address these and not to go too deep while scoring the Descemet's membrane in these cases, because these loose tags become the areas where you can have focal detachments. And just to share one case, this was a case where of a similar patient where we had posterior polymorphous corneal dystrophy. After peeling, in some cases, the descemet membrane just falls off. It is actually difficult to find a plane. But in those areas, sometimes you see posterior stromal tags. And if that tag is left alone, it can cause a detachment in that focal area. In this particular case, one of the more there was one more reason for causing a detachment was the area of the S mark was coinciding with the area where we had that loose tag. So it is like, obviously in the area where we have marked, the endothelium is not very healthy. It takes time to recover. So you can have focal detachments in those areas. Now, in long-standing DSEK cases where we are planning DMEK, there may be scarring at the edges. Sometimes in those cases, you see a lot of scarring, and while peeling off, while removing the graft, you see that the peripheral descemet membrane falls off and there's a recess over there. That needs to be addressed because while doing your unfolding, the graft can go and stick over those areas. So it is important to make the peripheral area also smooth as much as possible. In some of these cases, the patient may have undergone a non-stripping descemet DSEK, so it is important to remove the descemet membrane after removing the DSEK graft. This is one video of a patient where this patient had a DSEK long time back, and in the periphery, after scoring, it was seen that the peripheral part of the descemet membrane was scarred, and this had to be, and there was a descemet membrane region, it had to be removed. Now, the posterior stromal bed irregularities can also occur in failed therapeutic grafts. In failed therapeutic graft, DM stripping can come in fragments. It may not be very easy to peel off because in these cases, sometimes the descemet membrane is very thin, and particularly so when the therapeutic PK was done with a younger donor. So this particular aspect needs to be remembered while stripping the descemet membrane in failed therapeutic PKs. Thank you. That's all I have in this video.
Thank you, Dr. Sunita. That was a wonderful talk and lots of tips there for our newcomers. Dr. Samar, would you like to add some comments? Any comments from your end?
Hello.
About your technique for DM stripping?
DM stripping, that only one thing Sunita has commented everything except that under AR, when you have like aphakic cases, you have ACIOL, these are the two conditions where I want to do it under, I don't want to use any viscoelastic. Somehow I don't, personally, I do not like AC maintainer, but most of the time I do under viscoelastic agent. And AR, only those specific situation. And also I would like to mention in eye syndrome, descemet stripping is difficult. Sometimes there is a broad press and you have to be very careful because when you try to do the DM stripping at the same time, you may have iododialysis. So you have to be very carefully choose the area of, normally we choose a smaller graft for these cases. So eye syndrome is difficult, and also in post HSV endotheliitis cases, I have a series of 21 cases, and I have seen this, in these cases, the descemet stripping, they come in bits and pieces, not as a strip, because it gets adherent to the underlying stroma, and if you try to do hard, there is a chance of taking some stromal fibers, and if you get stromal fibers, what Sunita has shown, there is every chance of focal DM detachment post-operatively in those areas.
Thank you, Dr. Basat, and thank you all the faculty for answering the questions in the chat box. We'll go on to Dr. Audrey. She would be talking about her pearls about the graft delivery in DMEK. Over to you, Dr. Audrey.
Great, thank you. Let's see here. Just a moment.
Till Dr. Audrey gets on to the right slide, I would like to ask Dr. Namrata. Any tips from your end, ma'am, for DM stripping your talk will be following. We'll be following about the ASOC assisted. And do you do, what would be your pre-op examination in these patients? There is some issue about her not being able to unmute. We'll go on to Dr. Audrey's talk and take the question of Dr. Namrata later.
Great, thank you. I'm going to be speaking about DMEK graft insertion. As Dr. James also mentioned, I really like the goiter cannula. I have used all of the different varieties of inserting grafts, but I find that the goiter cannula gives the most consistent results and is the easiest. And so here are some tips, and then we'll go through the video and then go back through the pearls again. Before insertion, you want to check the graft position and orientation. You want to insert it beveled down. This is very important. You want to insert away from the pupil and position the cannula so that the graft delivery will potentially occur in the correct orientation. Again, this will all be in the video. I just want to mention these first. You want a gentle but firm fluid wave. That's also very, very important. Do not force. And so let's have a look at the video.
Dr. Audrey, we can't hear you. It's only the video which is playing.
So again, now you could see what that looked like. You want to be sure that before insertion, you check the graft position and orientation. You insert away from the pupil, bevel down. You position the cannula so that the graft delivery can occur in the correct orientation. And that's what I was talking about in the video, the V that you see. A gentle but firm fluid wave, and you want not to force. So what can happen if you don't have it bevel down and if you don't realize that? Well, you can have a little problem at the beginning of the case. You can have, you can catch the iris, and this is something that can happen. This is just a little teaser for the complication talk next weekend. We won't go through the whole video. And so because of that, we'll go through how you manage that next week. With the insertion of the cannula, you want to be sure you initially insert bevel down so that you don't catch the iris. You also want to make sure that the anterior chamber is deep enough in insertion. This is different from unfolding where you want to shallow it. And again, watch the iris. So what happens if you inject too forcefully, if you force things, and also you don't allow a couple of seconds before you withdraw the cannula? Well, you can get this. So for DMEK insertion, again, do not insert the DMEK graft into an overpressurized eye, or you will get the unhappy event of having the graft come out for you. And if there is resistance on the insertion, basically do not force it. You should have a little bit of resistance, but not so much. And so thank you. I find it helpful to show the videos a couple of different times, and that way after the main points, you can see it again. So those are my pearls. Thank you so much, and thanks for this opportunity to present in this great DMEK webinar.
Thank you, Dr. Audrey. We would like to know what is the amount of time you put the graft into the gentian violet? For how much time do you stain it?
Okay, well, I think it depends what country I'm in. And so here in the US, our stain, our trypan stains actually really, really quickly. And so it's maybe, 30 seconds or so. However, I know that, for example, if I'm at LV Prasad, that's going to be like 5 minutes stain. And so it's, the stain really varies very, very much to get the tissue to be stained appropriately. And so I think you have to know what your tissue stain does where you are at your institution.
Dr. Praveen, any comments on that?
I think it also depends on how old or young your tissue is. If I have a tissue from a younger donor, I generally like to stain it for a longer duration because the stain tends to make the graft a little stiffer. And if I already have a stiff graft from a very old donor, like say 70 plus, then I tend to stain it for a shorter duration because I want the graft to start to fold at the edges a little. Additionally, if I have a very deep anterior chamber, I would rather like my graft to be more rigid, so stain it a little more. But if you have a shallow anterior chamber, you'd like your graft to curl again, which is again where you would like to stain it less. Visibility again dictates the amount of staining, like Audrey mentioned, anywhere between 2 to 5 minutes probably would be the time to stain. Average would be about 3 minutes or so.
Thank you, Dr. Praveen, and thank you, Audrey. With a perfect staining, we'll go on to Dr. Vikas, who will be dealing with the most difficult part of DMEK, I believe, as a learner unfolding the graft. Dr. Vikas, over to you.
Yeah, thanks, Nidhi. I'll try to.
I think Audrey has to stop the share.
Yes.
I think just to answer the question which you asked Nidhi earlier, I think I would inject air to strip the Descemet's membrane in cases of CHED because I know the stain is not going to work that well and it'll become a little difficult. And I agree with Dr. Basak, iridocorneal eye syndrome is very difficult because it never comes in piecemeal and it keeps breaking.
Okay, Nidhi, I think I've shared my screen. You can see it, no?
Yes, yes. We
Okay,
are good.
great.
Yes.
Fantastic. I think it's a wonderful Sajjanath that's going on, and we have peeled off the graft and we know how to pick up the graft, how to see the graft orientation in the injector, and now the time is that the graft has gone inside. How do you unfold it? So I'll just, somebody asked how were in the chat box that how were the initial years. So you can see we started DMEK in 2013, and first year there were 60% failure rate, and when we analyzed it later, it was mainly because of the orientation, mainly in this step that we are discussing, we are going to discuss, because this is the most crucial step, and this has this is responsible for many failures. I hope now it works. Okay, so you check the orientation in the injector, then you inject in the AC. If you see that there's a part of your graft in the tunnel, you tap it on the surface so that it goes inside. Then you decompress a bit so that the DM roll touches the iris. The moment you have graft touch, it starts to unfold. Once you unfold, you create some ripples in the, you create some fluid waves, so that use that fluid waves to unfold the graft. And you can see with one cannula I was pinning it down, another one I was opening it. The centration is used by using two cannula technique. And once you know that your graft is centered well, you will inject the air and ensure that air is under the graft, and you go very slow. This you already have seen many of these videos in conferences as well as on YouTube. What I'm going to do is I'll just try to elaborate it a bit, that what exactly these taps and strokes are, what exactly is going on, what we have understood so far. So one very important thing is Descemet membrane in AC, it goes with the flow. You know, it is the how the fluid is going is the same way that your DM is going to go. So you need to understand it's a small membrane, and the concepts of DSEK will not apply here. And then you know, one is flow in and flow out. The fluid can go from AC to outside and then outside to AC, and the DM will follow that. Second is you can create some ripples, where the ripples are nothing but small waves within the AC to center the graft or unfold the graft. As you can see, these are the ripples. This is used to unfold the graft. It's a small wave that you use using taps, and you know, create ripples inside the anterior chamber. And waves is the larger ones where we use to shift the graft on one area or other. So movement of fluid in the AC can be created. And as I said, when you using two cannula and pressing it slightly hard, then you are creating a bigger waves to shift the graft from one side to other side. Suppose you want to stabilize the graft in one particular area, and you don't want this graft to move here and there. So what you do is you'll pin. What is the meaning of pin? You'll use a cannula. You'll press your cornea from up so that the back side of the cornea touches your graft. The moment it touches the graft, it will not move. Then this is like you have stabilized it. Then with the other cannula, you'll create ripples and, you know, unfold it. So the principle is to ensure the graft, there is a graft iris touch. The moment the graft iris touch happens, it starts uncurling. That is achieved by decompressing the AC, so that shallowing of the AC. Then you create these waves or ripples and unfold the graft the way you want. If you want your graft to move on the right side, then you'll have to decompress on the right side part, so that the flow, if you want the graft to go on the right side, you'll have to ensure that the flow is from left to right. Either you decompress on that area or you create the waves from the other side. Very important pearl is never ever inject the graft unless you are sure of the orientation, because if you have injected the air, then it will crush those endothelial cells. So ensure that your orientation is correct before injecting the air. So as I said, you can see this. So I have injected the graft. So what I'm doing is I'm tapping on the surface, creating those waves or ripples into that curl, into that the curl, so that it is that wave, a fluid wave will, you know, uncurl that particular fold, the DM roll. So first cannula now is, I'm on the left hand, I'm using the first cannula to pin it down. On the second cannula, I'm just tapping it a bit, creating some ripples within that DM roll. So once now I can see that my graft is on the right side, I want to shift it on the left side. So what I'm doing is using two alternate, just like you use the drumsticks. So what I'm doing is making some taps on the limbus so that the graft is shifting on the left. Now again, I'll pin in the center and unfold the remaining part of the graft. As you can see here, now the graft is unfolded. I know that with my orientation is correct. I'll center it a bit just by tapping on the surface and then inject the air. Again, I'll show you another case where injecting air is first very small air bubble, then slowly you increase it. Ensure that your orientation is correct. So what you can do is you can make these small aquarium kind of things. You can use any balloon, and this is what the wave is. You can see. So I'm using two cannula. When you press on one side and slowly goes forward, you can shift the whole graft towards the right. This is what the wave is that we can create inside the anterior chamber. And the ripple is when you are creating small waves. So what you are doing here is tapping on the one part. So if at the limbus I'm making a small tap, so there is small ripple. Then another tap, another ripple. So with that particular fluid movement, very gently the graft will shift from one side to other side. And how is this pin? You can see this is a folded graft. So you have to take it in one end. So from one end, then the area which is unfolded, you will pin that down, and the other area you'll create again those ripples slowly, and this will uncurl the graft. So if you understand, you'll have to be with the DM. Inside, you have to feel that how this is a very gentle membrane, and it has its elasticity, and these whole steps will vary. The age of the graft that you are dealing with, like the older grafts are more plastic, it is not easy to uncurl it. And it is very difficult for if you have a 65 year 70 years old graft. You have to ensure that your orientation is correct in the injector itself, so that it opens up well. And for younger graft, they tend to curl up fast, and then you have to ensure that you use all these methods to uncurl your graft. So that's it from my side.
That was a beautiful presentation, Dr. Vikas. Especially these diagrams and these things would be helping all of the new beginners to have an idea of what is the physics inside the anterior chamber of the graft. And that was very interesting. With that, we go on to the next talk of Dr. Rajesh Fogla. He would be also talking about his thoughts on graft unfolding.
Thank you, Nidhi. I think most of the points have already been shown by the previous speakers in terms of donor insertion and the tips for unfolding. So I'll just go over some of the few points. I think one of the important points is that you, as Audrey had also mentioned, that once you have the DM scroll inside your injector coming to the tip, you look at the orientation and you try to deliver the graft in a gentle manner into the anterior chamber, so that the open end of the scroll is facing towards the surgeon, that it's facing towards the cornea. So if you have the open end facing towards the cornea and not towards the iris, I think the unfolding becomes much easier. So let's look at a video. You get your tip into the eye and not do a wound assisted delivery. And Audrey had mentioned that you try and avoid getting the tissue getting caught in the pupil. So always try to get it across the pupil. And remember, don't be in a hurry to withdraw the injector tip from the eye. You can even release some fluid from the side port to soften the eye, or let the graft to open up a bit, secure your incision. And now you can see the scroll is already open, with the open end of the scroll facing towards the cornea and not towards the iris. So gentle tapping. You can either tap in the center, which creates two waves going towards the limbus, which can open up, or you can tap outside the area, or you can release some fluid from the main incision that opens up the scroll. Go in with the 30 gauge cannula, make sure that it's below the graft, and then you put an air bubble. So here is another situation. James will see that our patients have dark iris, so we need to have a slightly more dense stain to be able to visualize. And the corneas are not as clear as what you see in Fuchs. So in pseudophakic bullous keratopathy, the corneas are often not as clear as what you see. So here we have, it was like in a taco fold. So we are trying to get it into more like a double scroll configuration. So once we do that, we shift the graft to the opposite limbus. As Vikas had mentioned, that once you see, then the one end of the graft, you try to pin down using the tip of your cannula. And here I'm tapping outside the graft area. You can even release some fluid from the side port or the main incision to get this graft to open up. You can see the F stamp, so that tells you that's in the right orientation. Tap peripherally, and once you have the graft well centered, you can then go in and put in your air bubble. But before you go in and put in your air bubble, because if your chamber is very shallow, gently form the chamber, otherwise your tip of the cannula is likely to catch the iris. Always put a small bubble first, and then you can go in and enlarge. Now here, what I want you to pay attention is that if you see in this video, I had the initial bubble, and then when I went in, my tip of the cannula did not go inside the first bubble, and it created a second bubble. The second bubble actually detached the graft from this point onwards. So I had to go and just release that air, and then the graft was back into position. So this is something you really need to watch out for, because if you don't do that, you might think that you've done a great job, but then you may find that your graft is stuck in the angle. The other maneuver that you can do is, if your graft is opened up like this, you can pin down one edge of the graft, and then you can use the Dirisamer maneuver using the second graft in a drum roll technique to open up the scroll that you have. And you can see that that's what we do there. And we can see we have our F stamp here, which is in the right orientation. To move the graft, I like to tap in the periphery and not do the golf strokes, because if you do golf strokes, sometimes you can induce folds in the graft and it doesn't move really well. But if you tap in the periphery, but at the same time, your chamber should have some fluid in it. If it is completely flat, then you won't find that movement. So we inject a little bit of fluid, making the tip of the cannula go towards the iris, and then you inject, because if you just inject at the wound, the fluid will go in between the cornea and the donor, and your donor can get displaced. So once you have done that, you can do gentle tapping. You can see that when I use golf stroke, I get these folds in the cornea. But if you tap in the periphery or use the point of your cannula, you can move it much better. And then you can put in an air bubble. Before I put an air bubble, I always like to form the chamber a little bit. And then once I have my space, I go in with my cannula and I go to the center, and then you can inject. You can use a tuberculin syringe and just keep maybe 0.1, 0.2 cc of air, so that you get a small bubble and you don't inject a lot of air. Now, this is, sometimes we do get these patients with light iris. James had already shown that. So I'll show you here, the scroll was upside down. See it in slow motion. When you try to give a forceful injection of air, sometimes the scroll will move once, but then because the fluid is still moving, your graft gets flipped over once again. So always give a small, short burst to ensure that your graft moves only once and it doesn't go do a double. Once you have it in the right orientation, then you can shallow the chamber so that the graft doesn't displace. And rest of the maneuvers are the same as what I showed in the previous step, where you tap in the periphery and you can get the graft to open up. So you can see there, so always center the graft, because you don't have too much of space in the periphery. So when you move your graft towards the desired position, the final position, you can have peripheral space to move around. And then you can see by gentle tapping, you can open up the graft and then put an air bubble into the eye. I like to always use a 27 or a 30 gauge cannula, and always go to the center and then inject air. Because if you keep your cannula in the periphery and inject air, sometimes the air will displace the graft to the opposite side. If you have a vitrectomized eye or a very deep eye, I like to put a small air bubble on top of the graft within the scroll, and I can use that as a third instrument to try and get the graft to open up. And once your graft is opened up, and then you can gently aspirate this bubble and then put an air bubble below the graft. So you can see that I have opened up my graft. I was able to see the F stamp as well. I knew that we're in the right orientation. There you can see the F stamp there. And then you inject your air and your graft is well centered. If you have a younger donor, then I find this cannula very useful, which is close at the tip. It has two side ports, so you get lateral bursts of fluid. So you can orient the long axis of the scroll to the paracentesis, go in and with your tip of your cannula, go within the scroll and give a short burst of fluid. When you give a short burst of fluid, it converts that tight scroll into an open scroll. Don't be in a hurry to remove your cannula. Always depress the paracentesis to release some fluid, and then you can go in and tackle this graft to open it up pretty much the same way as what I showed you in my previous short videos. Here I'm releasing some fluid to again get the graft to open up, shallow the chamber. this is an older video. Using a single cannula, it's a little bit more difficult, but if you use a bimanual technique, I think it's you have greater control over the way you open up the scroll. So you can see the S stamp there that's in position. So this is the last video. There's a pull-through technique in eye with the ACIOL. So this is the endo-in technique where the endothelium, you manually scroll the donor with the endo-in, pretty much like a DSEK graft. Get the graft into the eye, and then I put an air bubble below it, and then you can manipulate the air bubble to open up the graft. And once it's in the desired position, you can put in a large air bubble. So these are some of the tips and tricks of various ways you can do the unfolding. Never use force. I think that's where you make a mistake. If you are gentle, I think you will have control over the way the tissue unfolds. And it doesn't take long. It takes on an average between 3 to 5 minutes to unfold, even in complex cases. But yes, there are some basic principles that you need to follow. And I think the less of force you use, the more control you have over the tissue. And the longer you keep manipulating, you get fibrin formation, and people who are doing DMEK, they will realize that the longer time they spend, the stain of the donor tissue also starts to fade, and you find that the control over the movement of the graft also reduces, and that's something to do with the fibrin formation that happens with the continuous manipulation with the tapping and everything. So try and do that. And one tip that I do before I put my donor into the eye is I do my DM stripping, and after that I put in a large air bubble to ensure that I have adequate amount of DM stripping, and this is after I've done the PI as well. And then I go and prepare my donor, which takes about 10 to 12 minutes. And within this time, because the air is filling the anterior chamber, it ensures that if there is any bleeding from the iris, that stops. But before I put my donor into the eye, I go in and give an AC wash. So what that does is, if there has been any blood or any fibrin that has formed in the anterior chamber, before I put in my donor, I wash it out. So that when I put in my donor into the eye, I don't have this problem of the donor getting stuck in the angle, or there is some abnormal behavior with the donor. Thank you.
Thank you, Dr. Rajesh. We'll go on to Dr. Namrata as we are running behind time. She will be talking about graft orientation. Dr. Namrata is Professor of Ophthalmology, Cornea, Cataract, Refractive Surgery Services at RP Center, All India Institute of Medical Sciences. Over to you, ma'am.
At the outset, I would like to thank Nidhi for making me a part of this excellent webinar on DMEK. Is my slide sharing?
Yes, yes. Just make it full view. We can see your slides.
Okay. And I would like to congratulate Nidhi for doing this webinar. I'm extremely proud of her. Before she got her fellowship into Shankar Netralaya, she was working with me at RP Center, and she had been an extremely bright mind and a great organizer there also. So kudos to you, Nidhi, and also I'm thankful to Praveen and Umang for making me a part of this. I would be talking to you about graft orientation in DMEK, and we are fortunate to have intraopacity microscope. I'm not saying that you need it. It's only that without having to make animations, I can probably explain it better, although others have done a great job. Great video by Rajesh, Praveen, and others, and Vikas. So there are no financial or proprietary interests. And of course, this is my first DMEK that I did. And at that time, we did have the microscope. So we didn't at that time have this S-shaped stamp. So we were just doing it without the S-shaped stamp, but using the intraopacity microscope. So after the Descemet's membrane is out, this is an IOL, in fact, injector. And there was a question on the chat, what am I using? So earlier we were using IOL injectors, and this is the Acrosoft cartridge which is being used with no proprietary interest. This is graft is placed inside, and the exact orientation of the graft actually you come to know through this. And what you have to look here is this, which is shown on the top here in red. And now you know that it is upside down. You can make out that it is upside down. So you have to give a squirt of fluid there to make it the correct side up. And now you know that it is the correct side up. And there is a gap which is present between the Descemet's membrane and the overlying stroma. And once you put air bubble there, it gets stuck to the back of the cornea, which can be seen here. And this is the post-op picture, and this is post-op at 1 month. This was a case of Fuchs dystrophy with cataract. Now, it is very useful. Then we started doing the S-shaped stamp when Dr. Basak came to RP Center again to do a workshop on DMEK for us. And this is essentially the way the DMEK roll is made. And then essentially the punching of the donor cornea with a 3 millimeter trephine is done, and this is then laid back. And I'm showing this because S-shaped is very useful, and although we do have an intraopacity microscope, we still use S-shaped to be doubly sure that the correct orientation is there, and this is useful especially in hazy corneas. So after you put the lid up, you can actually put a S there and then put the lid back. And after putting the lid back, one can then do trephonation from the endothelial side, and then can remove this DMEK roll. And by the way it rolls, and by the way you can see also on the intraopacity microscope, you know which side to load it into your injector if you already can see the way it is folding. Now in hazy media, it is very useful. For instance, in this case, you can hardly make out the Descemet membrane strands, whether they are coming out piecemeal or not. And then you can make them out on the intraop-OCT microscope. Then this is the goiter injector which is being used, the glass cannula. And here I have used a S-shaped stamp, but I can't make out where the S is. But I can make out on this intraop-OCT microscope how the orientation is. And when it is like this, with the curls, biceps curls up, then we know that it is the correct orientation. And then you can inject the air bubble so the graft gets stuck to the cornea. And there's one little trick that is there, which we tried in this case, was put a blob of viscoelastic there. So when the S is hazy or the cornea is hazy, if you put a blob of viscoelastic on the top of the cornea for a split of a second, you can actually see the S faintly. And this is in the post-op period. Now, this I've already shown, but just to reiterate, because the talk is of graft orientation, that in case it is not oriented correctly, and if you think that it is not oriented correctly, it is upside down, as can be seen here, then one can use maneuvers and can refloat it back by putting squirts of fluid inside and get it to the correct orientation. And when that happens, it is very important to unfold it completely and then inject the air bubble. There are sometimes, I think Vikas highlighted this very well, that if there are folds in the Descemet's membrane, sometimes, you know, it becomes difficult. Like in this case, the orientation was correct. You can see the S, but there's a little fold that is present here. Now, when that happens, what you have to do is with the cannula, you have to go above the graft and put some fluid there, and simultaneously from the other side also inject air. So air is injected from here, fluid is pushed from here. So this fold which is present here has now disappeared. But the important thing to understand is that you have to go between the graft and the cornea to do that unfolding. Of course, in eye syndrome, it gets a little difficult because there are a lot of corneoaridal adhesions which need to be taken care of. And again, after doing this, the cornea is also a bit hazy. So again, it gets a little tricky. And in these cases, again, if you put a blob of viscoelastic, this is again a goiter which is being used there. Then for a split of a second, you can see the S, which will be in the correct orientation. That is to say that even if you don't have this, put viscoelastic, just like you do phaco in corneal opacities, and you will be able to see that S there. Now, this was, of course, a case which was a failed DSEK for which DMEK was being done. And in this case, I just want to highlight the fact that what, in fact, Audrey was saying, that before even loading it in your cannula, it is important to know the orientation of the graft, because that helps. Now, if you look at this, this is again upside down. So get it into the correct orientation with the biceps curls upwards, and then load it into your goiter cannula, and then put it in the same configuration or the same side as would be correct. And here, of course, you can see the S also. You can confirm with the IOCT also. But again, whenever the S is hazy, you can put a block of viscoelastic. So for that split of a second, it will kind of get clear. So to conclude, you have to prepare the graft well. You have to load the graft in correct orientation. Minimal manipulation should be there when you're injecting the graft, because you want it to go like a textbook like picture, although it may not happen all the times. So just inject it the way you have loaded it in correct orientation. Shallow the anterior chamber. And I think I agree with Praveen that you can't choke the graft, because sometimes what happens is you don't know where the fluid is going to egress out. So I always like to make an additional side port opposite to the main wound to prevent choking of the graft, so that fluid can be released from all sides. Center it, because it's not like a DSEC graft that you can, put air bubble and then uh, uh, carousel it on this side or that side and get it to center. It will not. Air bubble means you've locked the graft there. Wherever your air bubble is gone, once it is gone means it will just get oriented in that direction only. And whether folds are there or not, whether it is completely unfolded or not, it will just kind of get locked there. Inject only when the graft is unfolded completely, and in case of inversion, of course, you have to refloat, orient, and oppose. And a third side port is always very useful. So thank you very much for your kind attention, and if there are any questions, I would be happy to answer.
Thank you, Dr. Namrata, and thank you for those kind words. I think having an AS society inside the OR is going to make DMEK absolutely, definitely much easier than for those who do not have. And with that, we'll go on to Dr. Praveen. He'll be talking about the air bubble management in DMEK.
Well, thanks again. Lovely talk as usual, Namrata, and lovely talks both by Dr. Fogla and Vikas with all your props. So thank you. So I'm going to sum up and end by talking about how the air bubble actually influences DMEK surgery at various steps, and mainly right at the end. So right in the beginning, the air bubble actually is quite useful to be able to identify remnants of Descemet's membrane. So there was a brief discussion about how you will strip your Descemet's membrane under heel-on or air bubble. One of the advantages of the air bubble, if you look at this area, this remnant DM that is present in the 11 o'clock, 12 o'clock position, the air bubble actually helps to identify that much more easily than using, this is a forceps that Audrey introduced me to, and this is a fantastic piece of equipment with the forceps that are blunt tipped and turned upwards, that you can get out little tags of Descemet's membrane that might be left behind, and once you've identified them with the air bubble as well. The other additional importance of the air bubble, like we saw in the earlier video, which I'm just repeating, is to prevent ingress of blood inside the anterior chamber, which is a really important function. So anytime your focus or your attention is not on the anterior chamber or not on the eye, like when you're preparing your graft on the side, always leave an air bubble inside the eye so that the blood or any external fluid does not enter the eye. And this will make sure that your anterior chamber stays clean, neat, and you don't have any surprises when you come back and look at your eye after you've left it alone for a while. Well, air can be undesirable as well, as you will see in this video. And this is an air bubble that I'm taking it out. You need to ensure that you don't have any air bubble when you're injecting your graft. So you see here that there was air in the syringe, and the air in the syringe will prevent the graft from actually moving inside the eye, because the graft basically needs fluid to be floating in. If it has only air, then it's not going to move. So you need to ensure that you remove and then deliver graft inside the eye. So air is not always your friend. But air can be very useful as well. The video that Dr. Fogla showed about using an air bubble in a very deep anterior chamber is again very, very useful from the point of view of unfolding a graft. So this is a Meles injector that I'm using, a broad tip at one end and a narrower tip at the other end. And you'll see that if there is air in the injector, it actually makes things difficult. But once you have your graft inside the eye, and you want to unfold your graft, an air bubble does two things. One, it'll help you to identify the plane. If you put an air bubble on top and the air bubble actually is opening up the graft, as you see here, as you move the air bubble, that means your air bubble and your graft orientation is correct. If you don't have an OCT, and then you can ensure you inject air over the graft so that you flatten the graft. And this is the Mellis's original technique, so that when you remove the air from in front of the graft is opened out and it's stretched out and flattened on the iris. It doesn't change orientation or position. And then when you put another air bubble, the AC is formed all over again. You also can use an air bubble when you have an extremely young donor and a very scrolled graft. So this is a donor from a 38-year-old deceased person. And you'll see that the graft in the eye is like a cigar. It actually scrolls quite a bit. And it is often difficult to unroll these grafts with just fluid because they tend to come back and scroll again, especially if your anterior chamber is a little deep. And situations like this is when a small air bubble, you don't need a very large air bubble like you saw in the previous video. A small air bubble actually will help to be your hand or your finger inside the eye, where you keep moving the air bubble inside the eye to help open up the graft. Like I said, again, this is again evidence that your graft is oriented correctly. You don't even need to check for your letter or your orientation if your air bubble, which is above the graft, is opening the graft so well. So once you do that, then you can just put a larger air bubble behind the graft, and then you can complete the surgery like you saw in the previous video. When you're injecting an air bubble, it's also important right at the end to be aware of where you're injecting the bubble. In this video, you'll see that the cannula is actually not turned blue, and when air is injected inside the anterior chamber, you will see that a number of folds are evident on the iris, which tells you that the air actually is above the graft in this situation. So whenever you're injecting air inside the eye, another important tip about why your incision should be short, you need to ensure that your cannula is turned blue as evidence that your air bubble is going to go behind the graft when you inject air to ensure that it adheres to the cornea. The other useful tip about injecting air is the fact that there was a discussion going on the chat about what you need to use to inject air. You need to use a syringe and a cannula that actually moves very smoothly. So when you inject air, as you see in this video, the air bubble actually should be a smooth single injection, and you shouldn't cause fish egging, where you have multiple bubbles that come into the anterior chamber that can change the orientation of your graft and move your graft to the periphery as well. So always aim to inject into a previous bubble if you already have a bubble inside the anterior chamber, and the injection should be smooth and in one go. Well, you also can use the air bubble to manipulate folds on the graft. If you look at this patient, you'll see that there is a fold between 12 o'clock and 2 o'clock. When this happens, you'll need to redetach the graft before you actually unfold this fold. But then what you can do is you can do something called bumping. So what you will do, and you'll see this maneuver in place here, is you need to reduce the size of the air bubble. The air bubble needs to be in place to hold the rest of the graft securely. But then you need to ensure that you move the air bubble away from the area of the fold. You'll see that's the area of the fold. So what I'm going to do is I'm going to move the air bubble away from the area of the fold, allowing the graft to be soaked again in aqueous, and then suddenly letting go again, so that when the graft unfolds, the air bubble again helps in unraveling the graft and then holds it up in the correct orientation. You might need to do this multiple times, but what is useful is to keep modulating the size of your air bubble so that you reduce the size or you form your anterior chamber so that your graft really doesn't go. This you can do if your graft is already partially attached and you don't want to change orientation. So you'll see that the fold slowly unravels and now the fold is completely gone. So that's how you'll actually use an air bubble inside the anterior chamber by reducing its size to ensure that any folds that are present on the DMEK graft also are gone. So just to summarize where you'll use the air bubble in DMEK surgery, you can identify remnants of the Descemet's membrane after stripping. Also remember that air can change the behavior of the graft inside the eye and will become very unpredictable. So ensure you don't have any air bubbles inside the eye when you're trying to unfold or change the orientation of the graft. You can use the air bubble to identify orientation by putting a small air bubble on top and moving the graph with the air bubble to ensure that it actually opens up. Air bubble can also help to unfold graphs that are tightly scrolled and also make sure that they hold graphs in place and don't allow them to move too much. At the end of surgery, what I typically do is achieve a full chamber air bubble. You don't need to increase the IOP a lot, just normal IOP. Keep the patient supine, check them about 2 hours after surgery. And if the air bubble is, the meniscus is above the inferior PI, I just send them home. If the meniscus is not seen inferiorly, then I gently tap the inferior incision to let out some air, and after that, start the patient on topical drops and send them home. So that's how I utilize the air bubble during DMEK surgery. Thank you.
Thank you, Dr. Praveen. And I think with that, we had a lot of discussion on the chat box, which has been answered by the faculty. I don't see any questions there, but we can take the questions on the WhatsApp group that we have with all the participants. Also, I would like to thank all the faculty and acknowledge their role for making this webinar possible. We have the second episode, which will be following next week on 14th of June at the same time between 5 to 7 p.m. Like to acknowledge the role of our IT team who has worked day and night to make this possible. They're still along with us. For the Konya team who has been backing me up with all the questions and all the inputs that I've been receiving. Dr. Audrey and Dr. James for getting up early in the morning out of their schedule. Thanks, James. Thanks, Dr. Audrey. Wonderful talks. All the national faculty, Dr. Vikas for all the props, Dr. Praveen for mentoring it out, Dr. Namrata, Dr. Satyal, Dr. Samar, everyone for being around here. We've enjoyed this, and I'm sure all the participants must have learned a lot. So we'll be back next week, same time between 5 to 7 p.m. We learn the tricks from all the mentors, from taking us out from the challenging situations in DMEK. With that, I would say bye to all the participants, all the faculty. Have a healthy, nice, wonderful evening. Goodbye.
Thank you so much, Nidhi. You are an excellent. I think you organize it so well. Thank you so much.
Yeah. Lots of hard work and fantastic job, Nidhi. Really good job. And good job by the SCH team as well. And thanks, Umang, for being a very good host. Thanks, everyone. Nice seeing all of you.
Thank you. Good night.
Bye-bye.